All right, guys, we are live. Just give me a second and I will get us streaming. Okay, nope. All right, guys, those of you joining us, give me a second. Like I said, it has been a weekend. There we go. Okay. All right, we are live. Good morning. Good morning, all. I know I'm running a little bit late today. So first off, I have to apologize. I know we were supposed to have CPR this afternoon. I'm going to have to cancel that. And I do truly apologize. I'm going to try to put something on a little bit later in the week. I'll keep you updated. This is a situation outside of my control. I don't normally share these types of things when they happen, but my mom is in the hospital and she was in the ICU. They're hoping to be able to discharge her today. So I have to be up there, you know, for the discharge and to get her out of the hospital. And then she'll come home with me for a couple of days. So I'm running and I do apologize. That's one of the reasons I'm running late today. She's doing well. She's recovering beautifully. But she had a very serious reaction to one of her medications. And you know how I say observations are important, right? So even little things we need to report. And thankfully she caught this pretty quickly, but she woke up at midnight and her mouth was swollen. She couldn't it's like, when you sleep with your mouth open during a cold and your tongue dries out and everything kind of gets like sandpapery. That's how she felt when she woke up. Within 30 minutes, her entire mouth, tongue, airway, everything was completely swollen and she couldn't breathe. So this was a emergency situation. But again, small things, if somebody says, yeah, they're complaining that their mouth is report that, because within 30 minutes, it had progressed to a full-blown emergency. So this is why these principles that I teach you are so important. If she had not gotten the help as quickly as she did, if she had not acted quickly, this would have been a totally different conversation. So thankfully, she's good. They're getting her meds sorted out. We now know what she cannot take. So, but I will be running up there today. So I do apologize. Like I said, I'll try to put CPR in later on in the week. I've got to look at my schedule. I haven't had a chance to look at my schedule. I have no idea what time I've got. But if you can't get it through me, it's okay. There's a million CPR providers out there. You can get CPR. Okay. But we'll see what we can do. All right. Yeah, guys, I know it's a little thank you. I appreciate your prayers and thoughts. Oh, good. We've got a congratulations. All right. Vivio says, good morning, everyone. I passed my CNA clinical from watching your videos online. Thank you so much. God bless you. So congratulations to you. We are super proud, super proud. Thank you, Vilma. I do apologize. Like I said, I don't normally share personal issues like that, but this is impacting you guys because I have to, and I don't ever cancel class, ever. So I do feel really bad about that. All right. So over the weekend, you guys had chapters 8 and 9, and I'm going to sit because it's been a long weekend. You guys had chapters 8 and 9. Does anyone have any questions on either one of those chapters? 8 and 9. So 8 is on nutrition. I want to spend just a minute talking about this because this is probably more important than you think it is. We truly are what we eat in a very real sense. And our patients are what they eat. So have you ever gone to, I got eaten up by no-see-ums and I'm allergic to them. So I'm like, have you guys ever gone to the movies and got a big bucket of popcorn? Okay. When you eat that popcorn, what does that trigger a craving for? What do you need to also have if you're eating movie theater popcorn? Huh? A soda. You got to have something to drink. Do you guys know why? You guys know why? When you eat movie theater popcorn, it makes you thirsty, like really thirsty. Okay. So let me explain to you why. Because the why is really important. So popcorn has a lot of salt on it when it's made by them, because that's what makes it taste good, right? All that butter and salt and yumminess. So the problem with salt is that it's really hard for the body to get rid of salt it's not using. Now, there's two main electrolytes in your body that control absolutely everything, sodium and potassium. So they control your heart rhythm. It controls your muscle impulses. It controls different metabolic processes in your body. Sodium and potassium are unbelievably important in your body. Too much of one or too little of another, and you're in the ICU. It's that simple. Okay. Now, the problem is that sodium and potassium are obtained through diet and regulated by your kidneys and your breathing and all your metabolic processes. So this is a very delicate balance. Okay. When you eat a lot of sodium, it's very hard for your body to get rid of it. So that sodium builds up in the bloodstream. Now, sodium doesn't go really into the tissues very well. So it kind of stays in the bloodstream like we talked about with the sugar. The problem is that we can eventually get rid of sodium, which we couldn't do with sugar. It doesn't get stored in the body like sugar did. We will eventually get rid of it, but it's a very long, complicated process. So until we're able to get rid of it, your body has to dilute it. So if we've got, good morning. If we've got excess salt, sodium in our bloodstream, the body isn't just going to toss it in the trash can. It's going to flood your vascular system with excess water. Everybody got that? To dilute that sodium level, get it to a nice normal place. Does that make sense? Okay. So let's think about that in relationship to our patients. Do you remember the blood vessel I showed you guys with diabetes that was all gunked up, right? Not a lot of room. So if we have a blood vessel that's all gunked up, not a lot of room in there, and it's got too much sodium, so we put more water in there, what happens to the pressure inside that blood vessel? More water. No, it can't expand, can't contract, but we're shoving more in it. We're blowing that balloon up. Say it louder. The pressure increases, and we call this blood pressure. So when we have a patient that eats a lot of sodium, what's going to happen to their blood pressure? It's going to go up. That's right. So when we have a patient with known high blood pressure, what kind of a diet do you think is going to be ordered? Low sodium. Do you see how the two are connected? Okay. So when you eat too much salt, your body kicks off a craving for drink. We call that thirst. And that is designed to help dilute the amount of sodium in the blood vessel. Now, the problem is when we're at the movie theater, so we thought we solved that problem, right? We have popcorn and we get a drink. We thought we solved that problem. However, at the movie theater, we're not usually drinking bottled water when we get that popcorn. What are we usually ordering with it? Soda. And soda has a high sodium content. So even though we're thirsty and we're drinking soda, we're actually adding to the problem. Does that make sense? Isn't that crazy? We think we're taking care of our thirst, and all it's doing is making us thirstier. But you know, water just does not go with popcorn. So when we're passing trays for patients and they're on a low sodium diet and we accidentally give them the wrong tray that has, let's say, canned vegetables, canning stuff, the preservative we use in canning is sodium. It's the best cheapest preservative out there. So you eat a lot more sodium every day than you think you do, just because of it's used as a preservative. Okay. So if we have a patient on a low sodium diet, we give them the wrong tray, then we could trigger a crisis in them, what we call hypertensive crisis, because they ate too much sodium and now the body has to dilute that, which puts more pressure inside the vessels. Now, interestingly enough, right, that new water that we're putting into the blood vessels to dilute it, that's got to come from somewhere. And we store excess water in our tissues. So the body takes some of the water from the tissues and puts it into the blood system. That's where the water comes from. Well, if we're shifting water from the tissues into the blood vessels, that means that our tissues are not going to have enough water, and we're actually going to initiate dehydration at the tissue level and an overload of fluid inside the vessels. So now we're dealing with competing crises. That doesn't sound good, does it? So I bring this up because as CNAs, we are the ones passing trays. We are the ones making sure that your patient has the right diet. And it's not a good idea to just say, oh, well, it doesn't matter, because it does. It matters really, really, really big. Does that make sense? Okay. So you're probably going to have a diet-related question on the state exam. Something like you're passing trays and you give two people the wrong trays. You mix them up. What do? You know, they've already started eating. What do? Do you just let them eat? No, we've got to take those trays away. Apologize, obviously. Take those trays away and get them the right trays. Don't just say, oh, well, it doesn't matter. It's just one meal. Who cares? The patient's going to care. The patient's going to care. In general, it can take up to 48 hours to straighten out a sodium imbalance. So this isn't something that we can take care of very quickly. It can take up to 48 hours to rebalance out a sodium imbalance. Okay, good. Questions? It's funny because patients will absolutely complain about a low sodium diet. They will absolutely complain. Yeah. And we can give them all the spice seasoning, the no salt seasoning packets in the world. They will still complain about no sodium, and they'll probably send a family member down to the cafeteria to grab a couple salt packets. Okay. Yeah, I saw that this weekend. So we need to be aware that, patients don't always like the recommendations we're making. So we have to work with that as well. All right. So any questions on diet? If the patient is on a low-fat diet, we're trying to reduce the amount of gunky buildup inside their vessels. If they're on a low-sodium diet, we're trying to maintain that sodium balance. If they're on a low-protein diet, that means their kidneys aren't working real well. And you definitely don't want to mess up those guys. So diets matter. Now, you might, as a CNA, be responsible for helping patients choose snacks. So if we have a patient on a low sodium diet and the patient says, I'm a little hungry, could you get me some snacks, something to eat? And these are your choices in the nutrition room, okay? You've got potato chips, pretzels, sugar-free Jell-O, or canned fruit. Jell-O would be our choice. Because remember I said anything canned is going to have salt as a preservative, so we want to stay away from canned. Potato chips and pretzels are absolutely salty. So the only option there that would be low sodium would be the sugar-free Jell-O. That's a question that you would get on the state exam. Or your patient has osteoporosis and is on a high calcium diet. Which of the following would be an appropriate snack for this individual? Toast with jelly, vanilla ice cream, sugar-free Jell-O, or potato chips. So which one of those do you think has the most calcium in it? Ice cream. Yeah, so in that case, ice cream is the way to go. So not all snacks are going to fit all patients. We have to know their diet order to make the right recommendations. Okay, good. It's funny because a lot of CNAs don't understand the correlation between diet and what's going on with the patient. And you'll always have saltine crackers in the snack room. And that's what they give out to everybody. Saltines to everybody. And remember, it can take 48 hours to correct a sodium imbalance. Okay. Let me turn my ringer off, but I am going to be checking my phone, guys. Sorry. Okay. All right. Chapter 9 was on rehabilitation. Part of that chapter went over different body positions. And I want to talk to you about that because that probably will be a test question on the written test as well. So you had things like supine and prone and lateral and Fowler's and Sims. Those are the 5 positions you need to know. Supine, prone, lateral, Sims, and Fowler's. And if you didn't read chapter 9, those words mean absolutely nothing to you. So let me go over them with you. I have a couple of memory tricks I use for this. So supine is on your spine. That's a pretty easy, correlation there. Supine is on your spine. So that means you're laying down on your back. Prone, posterior up. Okay. So in the prone position, you're on your stomach, your butt up, butt's facing up. So prone is posterior up. That's how I remember those two. You can use whatever memory tricks work for you. And then we have lateral. Lateral means on your side. And you're just going to have to memorize that one. Lateral means on your side. Then we have the other two, which are named for people. So supine, prone, lateral, those are all just positions. Sims and Fowler's are named for people. So the Sims position, let me tell you how I remember this one. And it took me a long time to figure this out. So I sleep on my side. I sleep on my side with one leg cocked up, right? And that's just my normal sleeping position. And I prefer to be on my left side with my right leg bent. So a mattress manufacturer, a big mattress manufacturer is called Sims. Sims mattresses. That is the Sims position. So Sims, mattress, sleeping position. So Sims is lying on your left side with your right knee bent up. It's a sleeping position. It's predominantly used, the Sims position is predominantly used if we're going to be giving an enema or doing any type of a lower GI scope work or something like that, because it positions the digestive tract in a way that allows us to work with the lower digestive tract very easily. So you'll see the Sims position usually if we're working with the lower digestive tract. And then we have Fowler's. Fowler's is just a sitting position. It's just when we do mouth care and we put the head of the bed up, that was Fowler's. So Fowler's is just a sitting position. Semi-Fowler's is half of a sitting position. So kind of reclining a little bit. The way I remember this one is that another name for chicken is fowl. So if you're going to eat chicken, you have to be sitting up. So Fowler's is sitting up. So those may or may not help you. You have to know those 5 positions because this is going to be used in everyday care planning. So you'll have a care plan that says patient must be in the Fowler's position from 7 a.m. to 9 a.m. every single day. And that's because we give a medication at 7 a.m. that can erode the esophagus if the patient's laying down. We need them upright until that pill digests so it doesn't erode the esophagus. So your care plan would say patient must be in a Fowler's position or full upright sitting position until 9 a.m. Okay. So you need to know those positions. All right, so any final questions on what you learned? Let me go ahead and get your scores. ALEXA. Thank you. Tanya? Kira?
For E and 9, it was 2 words.
Do you have 7 for me?
Yeah, I got a 95 and 7.
Thank you. Carolise? Naraya? Christopher? Jada? Peyton? Alex? Jessica?
I forgot my book.
That's fine. Rebecca? She's online. Amy?
I got both words.
Thank you. Fernanda?
90, 95.
Thank you. Stephanie?
95 and not done.
Fine. Shayla? Thank you. David? Ariana? Thank you. Owen? That's fine. Do you have 4? That's fine. No problem. All right. Any questions before we move on? Any questions? No? Okay. Let's see. Oh, thank you, Rebecca. Okay. Okay, got a couple questions here. Ow, ow, ow. Okay, I got a couple questions. Let me go through this really quickly here. Good morning. I was doing my exam on Wednesday, but I have to tell Miss Patty thanks because she shared a story about Prometric sending one of her students' date to a wrong email. I was also waiting on my date for 2 weeks. I called them and the same thing happened to me. One letter changed and they sent the email to the wrong email. I learned from that experience shared. We learned from her in every way. Oh, wow. I'm so glad you were able to catch that. Thank you guys for your good wishes for my mom. I appreciate that. I'll send them on. So yeah, I'm thank you for sharing that. It can happen. So if you're not hearing back from Prometric, you need to get in touch with them. Don't just keep putting it off because They may be they may be sending you stuff, but it's going to a different email. So be very, very careful with that. I don't want to see you, and Prometric doesn't give refunds, so I don't want to see you lose out. $155 is a lot of money. That's a lot of money. That's like significant grocery money. It's my electric bill. You know, it's big money. All right. One class left. You guys graduate on Wednesday. It went fast. It went fast. It goes fast for me. I know it goes fast for you. On Wednesday, you'll need to bring your yellow book back. I do collect those. Now, obviously, when we started this class on day one, every one of these seats was full. And as we go through the program, more and more people join us virtually that aren't physically here. But I need you to remember that on the last day, we all need to be here because I need to get your book back from you, but I also need to give you a graduation folder. So those of you that are joining virtually, I need you to physically come to class if at all possible on Wednesday. Those of you that are here, I need you to come to class on Wednesday. But when you come to class on Wednesday, I need you to be in the right uniform, black, blue, red, either any of those, because we will take a class photo. Now, I got an email from a previous student that I wanted to read to you guys because she specifically reached out to me about this. She said, "Hello, as a graduate from your course, I have found filling work as a CNA. My bosses always ask where I was trained, and I always sing your praises. However, my facility needs CNAs for the 3 to 11 slot. They will hire you on as a PCA for $15 an hour, and upon licensing, they'll pay $20 an hour. Please tell your students to apply to Windsor Woods Rehab. It's located off of Hudson Avenue. Have them drop my name, Jessica Shell, to Megan or Stephanie. Thank you. I hope this finds you well." So there is a previous student that just graduated out who is working, and the facility likes her so much they want to hire you. So she actually emailed me to let you know that so that you can go apply. So if you're in or near Hudson and you're looking for a place, they're willing to take you right now. Actually, a couple days ago when she emailed me. Windsor Woods. Windsor Woods. Jessica Shell. So lots of opportunity. The reason I say that is because we're going to take a class photo on Wednesday, and that class photo goes on my Facebook page. And my Facebook page is looked at by all of the employers in the area. Every time I put a class out, they look. And there's lots of times that they will put comments on there. "Hey, we're hiring. Please come see us." If you tag yourself in that photo or share it on your page, they may even reach out and give you an invitation to apply. So it's a good idea for you guys. If you want that interaction, it is a good idea to make sure that I don't tag anybody. I don't know who's in the witness protection program. I don't tag anybody, and I'll spell your names wrong anyway. So go in and tag yourself so that it associates you. Okay. And then feel free to share it. But one class left. Can't believe it. And then I have 3 weeks off and a cruise in there. So Cozumel and Roatan. Yeah, my two favorite ports. I love Roatan because it's Carnival, but I love Roatan because they've got this sky ride, like a ski lift, I guess you would call it, right? But there's no snow. Just over really high, but over all of this tropical stuff. It's gorgeous, and water out there, and it takes you right down to a beach. It's oh my gosh, it is my favorite. And the sky ride's like, I don't know, $15, well worth it. You can ride it all day long. It's well worth it. So I love Roatan because it's a nice beach day. I love Cozumel. We've been to Cozumel now about 30 times, and we don't go anywhere when we go to the port area, and then there's a little restaurant. I'll give them a shout out, Poncho's Backyard. A little restaurant, like a sandy area with tables, and you're literally from me to the camera to the water. So the cruise ships are out there, the water's rolling in, they serve the best margaritas. And I'll just pull, under an umbrella, palm trees, and I will sit there for 6 hours and just stare at the water. That truly is my happy place. And before my dad passed away, we took a huge family vacation there. So that's where I go to talk to Dad. So I love my time in Cozumel. So yes, I have that coming up, and I'm definitely ready. All right. The game show we will have not tomorrow, but a week from tomorrow. We will have the game show, and it's on Tuesdays at 11 a.m. You need to go to my YouTube channel for that. So youtube.com/foryourCNA. But that will be next Tuesday, will be the next game show. I'm not sure what the topic is going to be, but I write questions for every game show. So these are questions that you're not going to get anywhere else. But they're very, very test-specific topics. Okay. Oh, Jean says, good morning, Miss Patty. I have my test on 8:30. Oh, well, good vibes out to you. You're going to do fantastic. We have faith in you. Okay. My name, Renu from New York. I always watching your videos. And very good. Thanks for it. And soon I have my CNA test. Oh, good vibes out to you as well. And hi, Frida. Nice of you to join us. Okay, we're going to skip this slide because I'm not doing CPR today. Sorry, I got to go back up to citrus. We talked about this, but with only one class left, we got to talk about it again. So about this point, you're probably starting to wonder, where should I go apply? It's starting to get a little real. We're about to graduate. So a lot of you will automatically think, I want to go in the hospital. I definitely want to do hospital work. I don't want to work anywhere but the hospital. And that may work out for you perfectly. It might. But chances are, that's not where you belong. A lot of people have this conception in their brain about different workplaces that is not based on reality. It's based on TV. So we have to, or our own preconceptions, we have to think about our own personality and how that's going to play into our job satisfaction. So I see all the time in these Facebook groups that I'm in for CNAs, I see all the time, hey, I just applied to a rehab. How many of you rehab people like your job? Well, we have to think about this a little bit more than just where you work. How many of you guys have ever had a job? How many of you were happy with your job? Okay, very few. How many of you guys had complaints about your job? Okay. Now, I want you to say, those of you who had complaints about or didn't like your job, I want you to think about the job, right? Was it really the job you didn't like, or was it the people that you didn't like? Think about that for a second. Every job I've ever had that I hated, it was the people. It wasn't how far the car was from the building. It wasn't the color of the walls. It wasn't the physical work that I had to do. It was the people I had to work with. Either my manager was horrible and wouldn't support us, or wouldn't pay attention to time off requests and would schedule you, or wouldn't jump in if you were underwater, or wouldn't, yeah, that's huge, or wouldn't take your complaint seriously, right? So management plays a huge part in your job satisfaction. Coworkers play a huge part in your job satisfaction. If you don't like the people that you're working with, if they're very cliquey and you're excluded and nobody's talking to you and nobody's willing to help you when you need two people to transfer with a Hoyer and you can't find anybody and they tell you, no, you're the new kid, figure it out. That will lead into your job dissatisfaction. Pay will also be a factor. But if it's a good job and you like the people you work with, you're much more likely to stay, even if it's a lower wage. So when we're thinking about jobs, we have to remember that most of our impression is not based on the job. It's based on the people. So if I asked you, hey, do you like working at a rehab? You're probably going to say, yeah, it's okay. It's all right. And you're basing that off of the people that you work with and the tasks that you're performing, right? Now, I get in there because you said, yeah, it's okay. I get in there and I have an absolutely horrible experience because the people I'm working with on my hallway are horrible. Now, same place, same position, two totally different opinions. Who's right? Both. Absolutely. Both. So when you start asking people, hey, what's a good place to work? Understand that you're not going to get the answer you're looking for.
Why do you like to work there?
Right. Yeah. What is it that you like about working there? But understand that people are going to play a big part in this. And if you're not working with the same people, your experience is going to be totally different. And then you've got personality quirks. Now, I'm going to help you with that with this quiz. So some of you like fast-paced environments. That's me. I don't like to sit still. My brain always has to be running. So if I'm in a repetitive job where I'm just picking this up and putting it here all day long, that to me would be one of the most boring jobs in the world. I'm not going to do well. Now, if my job is to figure out the most efficient way to get these pins into this box, and I've got to use trial and error and problem solving, I'm your person. I'm all about that. Okay. So you have to kind of think about your own personality. If you're the type of person that does great with personal care, but you don't like beeping machines, yeah, the hospital's not the place for you. So we have to think about a lot of factors in deciding where the best place for us to work is, and I can help you with some of those through this personality quiz. There's 9 possible outcomes, and when you take the quiz, it's going to tell you, hey, you belong in a hospital, and here is why. The pay, the benefits, the pace of the environment, the opportunity for advancement, the opportunity to learn more, those types of things are the report is going to generate. And then down below that will be all the others. So you can click on those and see what makes other settings different than the one that you got. When I developed it, it took me 2 years to develop this quiz, guys. This was not an overnight thing. This took me 2 years to develop this quiz. And there's a ton of psychology in it, a ton of psychology. And you're not going to recognize it in the questions because they're super simple questions. But I tested it on over 3,000 currently working individuals. And it was scary accurate. So it will help guide you to the place that you're most likely to thrive right off the bat. Now, why do I care? Why do I care? Well, because we are a million CNA short out there. And if you get into the wrong position right out of the gate, you're likely to leave medicine entirely. If the very first position you get into is crappy and you hate it, you are going to think in your head that CNA work is not for me. You're judging it on one position in one location, but you will make a blanket judgment. Well, that doesn't help us get over the 1 million CNA shortage that we are in. I don't want to see you waste all of this money and time to get into a position that you absolutely hate. It doesn't benefit you. It doesn't benefit the industry. And that's why I'm really encouraging you to do this. Good. All right, we're not reviewing. Remember that you have review in the last class. We're not going to review. We're going to move right into the skills that we're learning today. So go to page 147. And today is the last 4 skills. This is it. We're almost done. There's not a ton of new stuff to learn today. We're focusing on toileting skills today. So bedpan, cleaning a catheter. Catheter care is peri care that we learned last week with an extra step. We're going to clean the tubing. But I want to explain to you what a catheter is and how it's used and take some of that mystery away, some of that fear away. And we're going to learn how to empty the drainage bag and measure urine using a measuring cup. So we'll learn that. And then we're going to learn the last range of motion that we didn't get to from class 2. That'll take like 2 minutes. So today is all about toileting. If you look on page 147, you'll see all of the principles involved there. We know all of them. Nothing new to learn. I do have a video for this. But if you look at the bottom of the page here, right here, you'll see that this is done on a live testing student. Now, if you look at the top of the page and you see what the name of the skill is, you might start to panic a bit. So assisting a patient with a bedpan is a live student, but it doesn't mean you're actually going to be peeing in a bedpan. This is going to be a simulation skill. So you will really be laying in the bed for real, but you're going to stay clothed, please. And we're going to put a gown on over your clothing. The person that's performing the skill will put a bedpan under your bottom, but you're going to stay clothed. They're just going to put the bedpan under your bottom. And at the end of the skill, they'll pull the bedpan away. But they're not actually going to touch you. And you're going to remain clothed. And there's nothing in the bedpan. Okay? So this is a simulation skill. But you can't really do this on the mannequins. You just can't. Because mannequins are too stiff. Yeah, they're too flimsy. It just doesn't work. So we really do need a live person for this, but they're not actually going to go. All right, so if you look at the top page 148, you can see the care plan, and it says patient has requested to use a bedpan. It says the resident with a bedpan. It says there that they are not wearing undergarments and can wipe themselves. So you might want to underline that. Not wearing undergarments, can wipe themselves. This is on page 140, not 148. I can't see 148. Oh, Kanisha. Kanisha says, hello, Miss Patty and everyone. I want to be a CRNA one day, and I'm trying to be a CNA. So congratulations. That's a great goal. CRNA is Certified Registered Nurse Anesthetist. So big goals. They make good money. Very good money. And it's great if you have the personality where you really don't like to talk to people too much. Oh, yeah, man. Anesthesiology is the way to go. Yeah. However, when things go bad, that is not the place you don't want to be at the head when stuff's going bad. But great goal. Great goal. Okay, so let's talk about how to get there, right? So certified, right? Registered nurse. So what do we have to start out with? RN, anesthetist. So that means additional training, right? So this is a master's level program. So you get your RN, which you can do in 2 years, your associates, then get your BSN, which you can do online once you're an RN, and then you tack on the master's. So it's about roughly 6 years of education, roughly.
Question is kind of short. Okay, so I took the TASE test twice,
Mhm.
and I literally missed both times by half of a question. Like,
Ooh.
yeah, like they have the questions where they have like more than one question or whatever. And I would, the first time I missed by half, and the second time I missed by a full question. So would you have like any recommendations on how you can study for that? Because it's like something that you either, I feel like at this point it's something you either know or you don't.
Right. And the T's specifically is a very general test. It's testing reading comprehension, basic math, basic science. So you're right. You either kind of have it or you don't. Now, there are lots of YouTube channels that are dedicated to improving T's scores. So I would definitely look into that. There's some books on Amazon you can get as well. Practice test questions, though, they help, but they don't teach.
Yeah, I have a book, and that's kind of what I was telling my mom. It's like, okay, I have the book, but it's like you open the book, and in a sense, you still kind of need like a guidance in a way because
Right.
you still don't really know. There's certain things you don't really know what you're looking at. You can't teach yourself.
Yeah, so I would look at YouTube, T's Prep, because there are some people on YouTube that don't just read questions out to you. That's so unhelpful, right? But they actually give lessons. Like, okay, today let's talk about science, and we're going to focus on, biology science. Let's do a quick biology review, and they'll kind of lead you through it, and then they'll give you a couple of questions on it. So, HESI is another one. HESI is more geared toward the health education or health sciences side, and it's going to be more sciencey based. But TEAS is just general ed, general knowledge. So let me explain to you why you have to take these tests. This is important. Let's talk about this. It is hard. It is hard. And the longer away from school you are, the harder it gets. Because your mind is taken up by all of your daily details. You're not really thinking about the stuff you learned in 5th grade. You're just not. That's why we have a game show. Are you smarter than a 5th grader? And most of us aren't, because we have real life stuff going on up here. The problem is that when it comes to nursing specifically, we only have so many chairs that we can put students in. There aren't a lot of instructors. So if these 18 chairs is all I have, right? These 18 chairs, and I really need all 18 people to get through the class and become RNs to go out there and work, because we have an RN shortage, like a serious RN shortage, right? So I need these chairs to be filled with people that are most likely to be successful. Does that make sense? Well, nursing education is very demanding. It's the hardest. The BSN is ranked as the hardest degree, period. Period. Now you're talking about against rocket scientists and, chemical engineers. And yeah, RN is the hardest degree to complete. Okay. So, because it's such a wide variety of things that we have to learn. So, if I've only got 18 chairs, I need all 18 to become nurses. That means that I need the people in those chairs to be likely to complete the program. That's why those entrance exams exist. Because if you have no reading comprehension at all, the RN program is going to drown you. It is literally going to drown you. So we got to make sure that you can read a sentence and know. I mean, if the sentence says Mary's wearing a yellow dress, and the question is, what color dress is Mary wearing? You've got to know that it's a yellow dress. You got to be able to have that comprehension that what you're reading means something. That's why those tests are there, is to help ensure that and not everybody is going to make it through but we're trying to stack the deck as much as possible. Now, that being said, I think that sometimes people just aren't good test takers. They have the knowledge, they have the ability, but they just aren't good test takers. And I don't like dictating somebody's entire future off of the results of one test. I don't think that's fair. So I understand why those tests exist and we need them, but I also think that it's a little bit unfair. YouTube. All right. Any other questions on that? I forgot what I was talking about earlier. It'll come back to me. Okay. So our care plan tells us the patient is lying in bed, is not wearing undergarments, and it can wipe self. That means that if you try to pull somebody's clothes off during the test, they're going to tell you stop. Don't pull their clothes off. If you try to clean them up after the bedpan, you're going to be told stop. The care plan says. So that care plan exists to direct you and what you're doing. Now, I'm going to tell you, when we're using a bedpan, a lot of times you're going to have to help your patient clean up a little bit just because of space. Okay. The bedpan is not very deep. Bedpans are not very deep. Visual aids. It's a bedpan. By the way, if it looks like a toilet seat, it's where the butt goes. Imagine sitting on that for a moment. That would be highly uncomfortable. If it looks like a toilet seat, it's where the butt goes. This goes underneath the bottom, right? Now, that means that the bottom is going to sag in there. That's not a lot of space, guys. Not a lot of space for the undercarriage to sag into. Furthermore, there's not much space here to reach in and wipe. Okay. You're starting to see logistically, our patient might need a little help with this. So if the patient needs help, we'll help them. But our patient, this care plan up here, does our patient need help with that? No. And what do we do with the care plan? Follow the care plan. So don't wipe anybody for the test. Okay. All right. I'll just lay that there for a second. Let's see here. Oh, Rebecca is giving you some guidance on the TEAS test. She says Mometrics and ATI. So, Kamisha says, will there be care plans on the CNA exams for the clinicals? And the answer to that is yes. So what do we do with those care plans? Follow them. We learned that on day 1. Follow those care plans. Move this because I will knock it over. All right. Remember, we need to read the care plan. Resident has requested a bedpan. The resident is not wearing undergarments, is able to wipe self, and it says the resident is able to move as directed. So for the test, that means you can ask the patient to lift their hips up. Care plan says they can. So that's the easiest way to get a bedpan under somebody, is have them laying flat, put their feet on the bed, and lift their bottom up like a bridge. Okay. And then we can put the bedpan under the patient. Good. Now, if they can't, she can't lift her hips. So if I need to get a bedpan under her and she can't lift her hips up on her own, then I would roll her on her side, put the bedpan under her butt, and roll her back on top of that bedpan. Now, when I want to take the bedpan out, I got to hold that bedpan flat because when she rolls, that bedpan will roll with her if I'm not holding it. So be careful, okay? Because the bedpan will roll with the patient, and then whatever is in that bedpan is now all over the bed. We don't want that. So if you're going to roll the patient, remember to put the bedpan under. You roll them on their side, stick the bedpan to the butt, and roll them back over on top of it. But when you take it out, hold the bedpan down and ask the patient to roll or help the patient roll off of it.
So back when I had a class, I broke my hip. And you say with the bedpan, for instance, I broke my right hip. So even though wasn't rolling on my right side, rolling on my left side to get a bedpan over there is still really painful.
Yes.
So, and it was just the one worker that was helping me, so kind of having my best. But in situations like that where you can't lift like yourself, but you're also in a lot of pain to where you can't necessarily roll to a full extent, what would you do?
Every situation is going to be handled a little bit differently with that, depending on the needs of the patient, right? So your situation, I would, because you're young, right? I would look at that a little bit differently than if I'm looking at a patient that's 92 with osteoporosis and bedbound, right? So rolling her on her side is still going to be just as painful as what you had, but I've got a whole lot more to think about with her than I do with you. So I would approach each one of those situations a little bit differently. In your case, it's pretty much a grin and bear it. We really don't have any other good options. I'm not going to ask you to just go, right? Because that's a dignity issue. And there's no way that your brain is just going to let you poop in the bed without something under you. It's just not going to happen, right? So we're going to have to deal with this as good as we can. So yeah, a little bit of pain. And unfortunately, here's the problem. If I medicate you before I put you on the bedpan, so let's say I give you some pain medication 2 hours before you get on that bedpan. Well, pain medication constipates you. So if I give you pain medication and put you on the bedpan, you're not going to be able to go. So we've got to handle this very delicately. But these are all things that as the nurse, I have to think about. Okay. Good. Makes sense? All right. So resident is able to move as directed on the test. So that's easy. We just ask them to lift their hips up and makes it easier for us. Now, I want to talk to you about the bedpan itself, though, because a lot of people think that this is like step one, and it's not. When a patient needs to toilet, we have to go through a whole list of options before we can even consider the bedpan. Now, this is part of the doctor's orders. Doctors actually determine how this patient is going to toilet. It's part of doctor's orders. But nurses are going to influence it. Nurses are going to tell the doctor, hey, I think they can transfer to bedside commode or whatever. We influence this, but the orders come from the doctor. Good? Makes sense? All right. So when a patient comes in and I do a head-to-toe assessment on that patient, I'm looking for real problems and potential problems. The first thing I'm going to ask myself is this patient continent, right? Able to hold onto their urine. We learned about incontinence last week. So is this patient continent? Well, if the answer is no, we're just going to clean them up every 2 hours around the clock. That's pericare. We know how to do that. But if they are continent, if they can go to the bathroom by themselves, well, now I've got some choices and I got to figure out the right way for the patient. Can the patient get to the bathroom? Maybe. If the patient is just there for blood pressure medication issues, yeah, they can probably walk themselves to the bathroom and use it, and I'm not involved at all. Ooh, I like those patients, right? So that's called bathroom privileges. They get up and go just like you do. We're not involved. Maybe they might need bathroom with assistance, which means they're a little unsteady on their feet. We're concerned about falling, but they can still go to the bathroom. So bathroom with assist. Now, if they can't make it all the way to the bathroom, we might want to consider a bedside commode. This portable toilet, we've got one over there. And we just bring it right beside the bed, and the patient gets out of bed onto the bedside commode and uses it like a real toilet, but it doesn't flush. So the CNA is going to need to clean it out. Okay, with or without assist. Depends on the needs of the patient. If they can't get to the bathroom and a bedside commode isn't a good option because we've got some broken hips going on and we can't get out of bed and onto no weight bearing. If these two won't work, now we're down to like our last resorts here. Catheter is a possible option for urine. Doesn't do anything for bowel movements, but it is an option for urine, but it has its own risks that we're going to talk about in just a few minutes. So what's my last resort? Yeah, notice it's last on the list. We didn't start out with bedpan. It is last on, it's actually below catheter. Last on the list. Last resort, yeah. Last resort. So let me explain to you why. Okay. Do you remember us talking about memories made when we were little? Being good quality memories, right? When are you potty trained? At a young age, usually before the age of 3, you've got the basics down. May still have accidents here and there, but you've got the basics down. So remember, memories made early are going to stick. Good? So you were taught from the time you're about this tall, don't pee in the bed. Don't pee in the bed. Don't pee in the bed. And certainly don't poop in the bed. So just because I come along and put a bedpan under your butt does not mean your brain is going to let you go. Because your brain is like, whoa, we were told don't pee in the bed. This is not good. I can't do this. And your patient may not be able to go. This may take 2 or 3 or 4 trials to get the patient to actually be able to go. Now, there's some other problems here beyond your own mind. Number 1, they're not overly comfortable. Number 2, you've got a complete stranger 3 feet away, separated by a curtain. They are going to hear and smell everything you're doing. You don't think that penetrates your brain? It does. And your brain's like, excuse me. There are too many. I don't go in an audience. There are too many people here. I'm not comfortable with this. Okay. And for some reason, and I can't tell you the psychology behind this, but for some reason, you're more comfortable going into the Walmart bathrooms with stalls, okay, stalls, than you are going in a hospital bed with a curtain. For some reason in our brains, that curtain is way inferior to the plastic hospital stalls. It's the same concept, but our brain sees it different. Do you guys see that? So a lot of times when we use a bedpan, your patient's like, I tried, but I can't go. And that's okay. That's okay. We'll try again. No problem. But if you go in there with an attitude like, oh, God, we just did this 15 minutes ago. Just go, would you? Now your patient is anxious. And what do you think that's going to do to their ability to go? Yeah, we're not doing them any favors. So there are a few things you can do to help here. Number 1, if the roommate is able to walk, exit the room, that's a great time to take them on a walk. Give our patient some privacy. Okay, good? Makes sense? Sometimes if we turn the water on in the room, the sound of water will help with urinary letdown reflex. If we preemptively address odors, a little air freshener beforehand goes a long way. Make sure that the fan is on in the room or the bathroom, you know, to handle any odors, that type of thing. We want to make this as comfortable for the patient as possible because we're already starting out from a point of discomfort. Okay, good. All right. So you guys understand that bedpans are a last resort? All right, now there's another problem with bedpans that we haven't even talked about. When your patient is sitting on this, right? So their butt is here, they're peeing in. Pee is under pressure. I want to show you the side view of this because remember we got an undercarriage that's sagging down. There's not a whole lot of room here, okay, between our undercarriage and the bedpan. So when that pee under pressure hits the flat plastic surface of the bedpan, you will get splashback. Now, normally you don't get a whole lot of splashback when you're peeing in the toilet. And when splashback occurs, it's probably going to make you clench. And what does that do to our ability to pee? It stops it. So that's a problem. Okay. Another problem with bedpans, there will be splashback just because of the mechanics of this. Now, there's something we can do to help that, but you have to ask the nurse. If the patient has to have a bedpan, we want to ask the nurse 2 questions. Number 1, are we keeping track of intake and output? Remember intake and output we talked about last week? So intake, we're measuring all the fluids that go into the body. Output, we're measuring all the fluids that come out of the body, including urine. So if the patient is on intake and output, we can't help this because we're going to have to measure the urine. We can't do much about that. But if they're not on intake and output, then we're going to help our patient tremendously by taking toilet paper and making big loops of the toilet paper, 5 or 6 big loops. And then we lay it in the bottom of the bedpan and it absorbs the urine as it comes out. We get rid of splashback. It also keeps the urine from sloshing around. And it helps with odors as well because it captures that urine. Okay. So if your patient needs a bedpan, big loops of toilet paper in the bottom of the bedpan will help them tremendously. If we have to measure the urine, we can't use toilet paper because you can't soak it up. Good? Make sense? Okay. Now, the second thing that we can do, have you ever worn shorts and sat in a car in the summer in Florida on leather seats? What does your skin do? It sticks. Okay. So when we have warm plastic, because it's not really leather, it's plastic. If you got warm plastic against skin, you're going to stick. Well, warm plastic against skin. So when we go to take this bedpan out, it's going to stick to their butt, especially if they've been on it for more than 5 minutes. Because remember, our body temperature is 98 degrees, 98.6, but you know, it's hot. And it's going to warm up this plastic and your patient's going to stick to it. So when you try to take it out, you're going to be like, right? So what's in here? Yeah. Where's the pee now? Everywhere. So that toilet paper in there will help you with that. But we also want to ask the patient, can we use powder, or the nurse, care plan, can we use powder? If you just sprinkle a little bit of cornstarch on the top, little powder, little something up there, it helps the bedpan slide under and slide back out easily. No problem. But if our patient has an open wound, we don't want powder anywhere around there. If they have a respiratory condition, we can't use powder in the room. There's a lot of reasons why powder may not be a good idea. Whose input do we need? The nurses. Are you starting to see that there's a lot of little details here that you didn't think matter but might? That's why we have to get the nurses' input on everything. Even something as simple as putting toilet paper in the bedpan has to get approved. It has to be on the care plan. Good? Okay. So we ask the patient to lift their hips. We put the bedpan under it. Looks like a toilet seat's where the butt goes. So bedpan under. And the patient's going to pee into the bedpan, and we're going to take it out. And for the test, we're going to empty it into the toilet, rinse it, dry it, store it. We don't have to measure it for the test. But we're also not going to use toilet paper because they're not really peeing. Good? All right. Everybody thinks that those are the important parts of bedpan, and they're not. They're not. The important part of a bedpan has nothing to do with the bedpan itself. It has to do with positioning. So if I've got a patient in a bed, so patient in a bed, okay, and I bring along a bedpan and I put it under my patient in that bed, what did it do to their middle? How many of you ladies can pee uphill? How many of you can have a bowel movement uphill? You're fighting gravity here. It's not going to be effective. Now, for urination, men use something called a urinal. It looks like a little milk jug with a handle. So most of the time, men will use a urinal for urination, not a bedpan. But bedpans are used for both urine and feces for women. So this is no good. If we put the patient on a bedpan and they try to pee, that pee is going to run right up their back into their hair. And that's pretty gross. That's if they can go at all. So the most important step of bedpan is to get them in a normal elimination position. The head of the bed up is the most important step because none of the rest of it matters if we don't get them in the right position. Does that make sense? And this isn't a step that you'll think about on your own. You would have just put a bedpan under a patient and been done with it. And that's not going to help your patient. Does that help you?
Makes sense now. Now that I think about it, even before my incident and the ALS and stuff, I've known mostly about the bedpan, but I never really. Now that I think about it, I don't ever think I remember seeing anyone really sitting.
Yeah, and you're not going to be able to go effectively. You're not going to empty your bowels, certainly, in a laying position. Good? So that's kind of that hidden step that nobody thinks about on their own, but it's the most important step for the test. Put the bed up. Yeah. Now, there's a problem with that, though. When you have a patient in bed and we put the bedpan under the patient and we sit them up and they go, now their butt is pressing that bedpan down into the mattress. So you guys sitting where you are, go ahead and lift your butt up off the chair without using your hands. You can't. You have to stand up, right? Yeah, that doesn't work. So you can't get this bedpan out from under the patient when they're sitting on it. You just can't. So we need to get the head of the bed back down to a laying position, have them raise their hips so we can take that bedpan out. Okay, yeah, it could be stuck. So we got to really work at it a little bit or use powder.
When you're moving the head of the bed up and down, like you know how sometimes it changes, it shifts.
So we're going to get sloshing. That's exactly where I'm going. Yeah. Whatever's in that bedpan is going to slosh around, right? And that's where the toilet paper can help. But we have some sloshing going on. So what might we be able to put on the bed that is absorbent and waterproof? A Chucks. Yeah. So the first step of this is to put a Chucks underneath the patient, put the bedpan on top of the Chucks, and then put the head of the bed up. Give them toilet paper, let them go. Then we're going to put the head of the bed back down because you can't take the bedpan out if they're sitting on it. Head of the bed back down, and we're going to take that Chucks and bedpan out together. Okay, good? Make sense? Good. So the reason for that, and it's a really important reason here, is that whatever's in that bedpan is likely to shift with all of this movement of the bed. So we don't want that to get on the sheets and then ignore it. You don't want your patient laying on dirty sheets. So the chucks become super important, but we don't want to leave a chucks under a patient that doesn't need one, because chucks are waterproof. I mean, they're going to hold in body heat. So what's that going to make the patient do? Sweat. So under the sheets, if we've got a chucks and we've got a sweaty body on the chucks, now we got warm, dark, moist. And that's not comfortable, but it's also going to lead to pathogen growth. Good? Makes sense? Everybody good with that? Okay. So we put the chucks under there the way we do everything else. Clean rolls toward me, dirty rolls away. We already know how to do that. Nothing new there. So we put the chucks on the bed, and then we're going to put the bedpan on the chucks under the patient, having them lift their hips. These beds, the head of the bed goes up. Cool. But the bed bends where the body bends, which is right there. That is where your body bends. So when you put the head of the bed up, that bedpan may shift a little forward or backward. Just have them adjust it until they're comfortable. It says they can move as directed. If you have somebody who can't move on their own, you may have to work at this a little bit to get it in the right place. But for the test, just they can adjust it. Says they can. Care plan says they can. So we're going to make sure they're covered at all times. You can keep the sheet on them. All right. Timeout. I'm not going to, this is off the record. Okay. Off the record. That checklist does not make you use a privacy blanket. Does not make you use a privacy blanket. You can leave the patient's sheet on them to cover them. Remember, no knobby knees, right? We can keep the sheet there. But you've got pee under pressure coming out. You've got splashback. And that splashback may get on that sheet. And that sheet's tucked in at the bottom of the bed. It's going to be in your way. So if you do this with just the sheet, you need to look at that sheet really close to make sure that it's not dirty after this skill. For me, a better way is a privacy blanket. So I'm teaching you to use a privacy blanket for this skill. It's not required for the test. So the partner that you have may do this without a privacy blanket and be just fine and pass the test just fine. I want you to be a little better than that. Okay. Keep that sheet clean. Otherwise, okay. Otherwise, you may be inadvertently leaving the patient on covered with a sheet that has body fluids on it. All right, so we've put chucks under the patient, we put the bedpan under the patient, we put the head of the bed up, we're good to go. But do we want to touch this bed controller with those butt juice gloves? Right? You put a chucks under their patient, and if you remember the care plan, it says they're not wearing undergarments. You touched bare butt. You need gloves on for that. So your gloves have been under that patient's bare butt. You have butt juice on those gloves. Okay? Do you want to touch that bed controller with butt juice gloves? No. So we're going to take our gloves off and then put the head of the bed up. Good? Now, for the test, you have nowhere to go. You have no other patients. This is it. This is the only one you got. And you've got no other rooms to go into. You are stuck in this room with them. But you don't want to stay. How uncomfortable would it be if I walked into your bathroom and just kind of stared at you while you tried to go? Right?
Go outside.
Yeah, that's really creepy. Huh? Yeah, no. You need privacy for this. I do not go with an audience. It's not OnlyFans. So, yeah. So, you on the test, need to stand on the other side of the curtain and give them a little bit of privacy. Ideally, in a clinical setting, don't be in the room. Wash your hands, go take care of somebody else until that call light goes off, or check on them in 5 minutes. It's fine. But don't just stand there because it's very uncomfortable for your patient. Do you guys get that? But for the test, we're just going to step on the other side of the curtain and wait for our patient to say, I'm done. So when you're the patient for this, you're going to get instructions. Your instructions are going to be, don't really pee. They're going to put you on a bedpan. Once they disappear from view, just say, I'm done. And then you'll hear that and you'll come back around the curtain and finish up because they're not really going. Okay, good. Questions? All right, so we might have to make sure they have their call light and their toilet paper because it says that they're able to wipe themselves. And then once they say they're done, we're going to lower the head of the bed. After we lower the head of the bed, then we can put our gloves on and take the chucks and bedpan out together. We do not carry an open container of urine through a room, period. No one needs to see what's in that bedpan. That's a privacy issue. But it's also an infection control issue because if your shoes are untied and you trip over your laces on the way to the bathroom, you are going to end up face first in that pile of urine or whatever else is in the bedpan. It is an infection control issue. So we do not carry open containers of human waste anywhere. So in order to fix that, we're going to take the bedpan and the chucks out together and wrap the chucks over the bedpan. Yep, because we're going to throw that chucks right away as soon as we get to the bathroom. We're just using it as a bedpan cover. Okay. So we're going to take the bedpan to the bathroom, throw our chucks away, and we're going to empty the bedpan into the bedside commode or the toilet. There's nothing in there. You're going to pretend. So you take the bedpan over to the bathroom and you dump it into the toilet. Nothing there, but we're going to pretend. Dump the pretend pee into the toilet. We're going to rinse it. Where does the rinse water go? We're going to dump the rinse water in the toilet. And then we dry it. And then we put it away like we put away everything else. If you remember, the care plan said our patient was able to wipe self. We didn't do that for them, but they wiped themselves. So we know where their hands have been. What do they need? Yeah, they need a hand wipe. Don't forget this because we don't want our patient to pick up their tuna salad sandwich later. Think it through. All right. And then we can remove that privacy blanket, restore the sheet, and do our closing. Okay, good. I'm going to talk to you about bedpan cleaners. These things are awesome. A bedpan cleaner is going to be found in acute care settings like hospitals, rehabs. Not always in nursing homes, sometimes in nursing homes, but not always, and rarely in assisted living. But they do show up occasionally. Now, what this is, if you've seen a clinical toilet like this, you've got this little thing that looks like a shower head sticking up there. If you bend that forward, it actually pivots forward. If you bend it forward over the toilet, it'll spray down into the toilet. And this is how we clean bedpans. Yeah. So we can rinse it out right over the toilet. That way we're nowhere near the sink, which is pretty high on my gross meter. So right over the toilet is good. Now, the problem is you've got water under pressure hitting a flat plastic surface. So we're going to have splashback. Now, I don't want the patient's waste products all over me. Remember, I got some portals of entry here that I want to protect. So mask shield is a good idea. You don't want urine or feces in your body openings. I'm also going to cover my clothing with one of those yellow, where is it? I don't know where it's at. One of the yellow isolation gowns, just a disposable gown, because I don't want small particles of feces or urine up against my uniform. We already know it's dirty, but we don't want to really make it dirty. This thing has to go home with me. I got to get into my car. Good? Makes sense? So if you're going to use a bedpan cleaner, dress for the job. Gown, mask, eye shield. A word on masks. Masks do not filter odor. Just regular masks that we wear does not filter odor. If you are particularly odor sensitive, you'll outgrow it eventually. But until you do, if you put, the Vicks stuff that mom used to put on your chest when you were a kid and had a cold, you get a little small bottle of Vicks and you just put it right underneath your nose, it helps cut odor that's coming in. It'll make you less sensitive to it. I can't use Vicks because of that. The menthol is, I'll look like Rudolph in like 0.2 seconds. I just get all red. So that doesn't work for me. But what I do is go and get a little jar of Vaseline. They used to have them like at the Dollar Tree, whatever, and put a couple of drops of my favorite essential oils in them. And you want to make it somewhat strong, right? So you can smell it, not real light. And I would use that right underneath my nose. And I like lemongrass or orange blossom. Those are two good scents. And it helps cut down odors a little bit when you need it. But overall, over time, you will develop a little bit of a desensitization to odors. But that will help you. Just remember, masks don't really do a whole lot to filter odors. Good? All right. Bedpan positioning. Remember, the bed part of the bedpan that looks like a toilet seat goes under the butt. All right. These are our steps for bedpan. This is it. We're going to ask our patient to lift their hips or roll them over on their side. For the test, just ask them to lift because they can. We'll put the chucks under the hips. Are you able to lift your hips now? Okay, you got full range of motion? All right. Sometimes after a broken hip, a broken pelvis, you don't. So if you have if it hurts or you have any limitations of motion, let the evaluators know when they check you in, because they're going to ask you, do you have any conditions that would keep you from being a patient for any of these skills? Just say, I've had a broken pelvis. And that means that they won't use you as a patient for this one. Okay. Just tell them I had a car accident, broken pelvis, and they'll adjust. All right. So we're going to put the chucks under the hips. We'll position the bedpan, ask them if it's comfortable, raise the head of the bed, give them their toilet paper and call light, lower the head of the bed when they're done, put our gloves on, remove the bedpan and chucks. We'll cover the bedpan with the chucks for transport, clean and store the bedpan, remove our gloves, and give the patient a hand wipe. Those are our steps here. Any questions on this one? All right, I'm going to show you the video. Mm-hmm. All right. Let's see here. Hold on. Oh my God. Thank you so much, Miss Patty. I'm an aide for over 8 years now. I've followed all your videos, passed with flying colors. You're amazing and educational. Thank you so much. That's awesome. Let's see here. Yeah. And this person is nose blind at this point. So yeah, you do get desensitized to it. So good input. All right. Let me get your video up here.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
Good, how are you?
Wonderful. I understand you need a bedpan. Can I assist you with that?
Sure.
I'm going to close your curtain, wash my hands, get my supplies, and I'll be right back. Okay, I'll need a chucks and a privacy blanket for this skill. Okay, Mr. Jones, I'm going to place this privacy blanket over you.
This will help keep you warm and protect your privacy as we do this skill. Is that okay?
Yes.
Okay. I'm going to spread this out without snapping it or shaking it. And I'll have you hold this in place so I can pull your sheet down. That way your sheet remains clean as we do this skill. Okay, I'm going to prepare a chucks to place under you before we put the bedpan in place. I'm going to hold the chucks up lengthwise and roll it toward me. Clean rolls toward me, dirty rolls away. And I'll just place this on the bed. I'm going to open the drawer that the bedpan is in and get a set of gloves. Okay, Mr. Jones, in just a moment, I'm going to ask you to bend your knees, lift your hips as high off the bed as you can, and I'm going to unroll the chucks underneath you. Okay?
Okay.
All right, go ahead and bend your knees and lift up. Okay, and you can relax. I'm going to go around to the other side of the bed and unroll it. Okay, Mr. Jones, can you lift up again, please? I'll smooth the chucks out, making sure it's positioned properly on the bed. You can relax. Okay, now I'll get the bedpan out from in the drawer. And I'm going to place this under your bottom, if I can get you to lift and relax. Is that comfortable?
Yes.
Okay, I'm going to put the head of the bed up, but let me remove my gloves first.
Okay.
Okay, I'm going to put the head of the bed up. Please tell me when you're comfortable.
Okay.
And you may have to adjust that bedpan a little bit as it moves. Tell me when you're comfortable.
That's good.
Okay, here's your toilet paper and your call light. And I'm just going to wait out here. Please let me know when you're done. Okay, Mr. Jones, I understand you're finished. Let me help you with that. I'm going to put the head of the bed down now. And please do not lift your hips. Once the head of the bed is in the lowered position, I'll put on a pair of gloves. And I'm going to hold that bedpan flat as you lift off of it. Okay, Mr. Jones, I'm going to take a corner of the chucks and hold the bedpan flat as you lift off of it. You can go ahead and lift on the count of 3. 1, 2, 3. Thank you. I'll remove both the bedpan and the chucks and take them to the bathroom for disposal. I'll be right back. Once I get over here to the bathroom, I'm going to unwrap the bedpan and we'll throw the chucks away. I'm going to empty the contents of the bedpan into the toilet, and then I'll rinse the bedpan. We'll deposit the rinse water into the toilet as well. And then we'll set the bedpan down to dry. I'll pick it up with a paper towel. I'm going to dry the inside. We'll throw that paper towel away. I'll dry the outside, throw that paper towel away, and get one for the drawer. Okay, I'm going to place the bedpan in the drawer along with the toilet paper. And we'll use the paper towel to close the drawer. Now I can remove my gloves. Mr. Jones, would you like to wipe your hands? Thank you. Okay, you can relax your legs if you'd like. And I'm going to pull your sheet up and remove the privacy blanket. We want to make sure that we roll the blanket in a ball so that any trailing edges don't contaminate other surfaces. There you go. Here's your call light. I'm going to go put this in dirty linen. I'll be right back. Okay, Mr. Jones, are you comfortable? Is there
Yes.
anything else I can get for you while I'm here? A
No.
magazine,
Thank you.
perhaps? Your call light is there. Please let me know if there's anything that we can do. I'm going to open your curtain and go wash my hands.
Thank you.
After washing my hands, I'll review the steps of my skill, make any corrections, and then tell the evaluator my skill is done.
Okay, there's 2 comments here. Ask her anything. She's awesome. You have 25 skills. She'll cover anything you need to know. Don't be afraid, please. Good luck, future nurses, and welcome to. I'm not going to say that word, but yeah, it can be being in the healthcare field can be a little cultish. Marie says, "Good morning, Miss Patty. I've been a CNA for 2 years. Thanks to your videos, now I want to be an LPN. Can you advise me, please, on how to get started?" So this is a great question, and then we'll go on break. So LPN is kind of the next step. If you wanted to climb the ladder, you can go straight for RN. That's fine. I usually recommend that you get your LPN first. And the reason for that is this. It's all about time and money. It really is. It boils down to time and money. So LPN is the first year of RN school. So RN is 2 years. You got to do your prereqs and then 2 years of school. Okay, 2 years of the RN program. The first year is LPN. So, so they actually take that out and teach it as a different course. So LPN. Well, if you get your LPN, now you're making LPN wages while you're going to work for the last year of the RN portion. Where if you do it, if you go straight for RN, now you're 2 years of making CNA wages. So it makes more sense to get your LPN, make more money while you're going to school as your RN, for your RN. So that way you only have to work half as much during the hard part. Does that make sense? Okay. So it all has to do with time and money. So how do you become an LPN? Well, most of those are done in vocational schools. So you primarily want to look for a state vocational school like PHSC or something. And that's because it's going to be cheaper and easier to get into. Private schools cost a whole lot more, but you're pretty much guaranteed entry as long as you can pass the test. So there's going to be an entrance test. Go to YouTube and, brush up on that. But as long as you can pass the test, you're going to be into a private school, but they're going to charge you. So the education is standardized. It's the same. Doesn't matter where you go. It's all the same stuff you're going to learn. So it really doesn't matter. For me personally, I want to pay the least amount of money I can for that if the education is the same. When you are applying for jobs and you're starting to go to interviews, if you know you want to go on for nursing, that is a great interview question. Do you guys help with tuition reimbursement if I want to advance? A lot of places do. So you'll take a class, you'll submit your grades, and they'll pay you back for that class. So that would be good. Some places have just a flat education benefit. All of our people get $3,000 a year for education, put towards education, something like that. So you want to know what their program is, if they have one at all, and that'll help you narrow down where you want to work as well. Remember that those benefits are super important in your decision-making process if you want to go on. It takes 1 year, Helen, to be an LPN. If you're going part-time, it can be up to 18 months, but if you're full-time, it's 10 to 12 months, 1 year. And I've been stuck as an aide. I became a team leader at my job and have had such a great resume ready to help level up. With tuition programs. Yeah, absolutely. Absolutely. All right, guys, we're going to go ahead and take our break. 10:40 now. We are on 23. We're going to go ahead and take our break. And then when we come back, we'll go through catheter care, emptying the drainage bag. Those two kind of go together. But I got some things I need to teach you about the catheter. But those two skills kind of go together. And then we'll get our last range of motion in. And that will be it. You should have some practice time built in today. So, all right, guys. Go ahead and go on break. All right, Rebecca, she does say something here. I don't think you can challenge the LPN with 1 year of RN school. Maybe it has changed. There are actually a couple of states that do allow you to challenge the LPN. Florida's not one of them, though. Okay, so let's get into catheter care. So if you look at page 158, this tells you all the principles involved. So basically everything but shoe rules, just like peri-care. There's not much to learn here. We already know most of this skill. So we're going to go over the principles that are involved in this, and you should kind of understand how the skill is performed. But we want to talk a little bit about catheters themselves. I need to demystify catheters because people are just scared of them. And they're not nearly as scary as people think they are. And a little bit of knowledge here goes a long way in increasing your comfort with catheters. So if you go to page 159, you can see the care plan at the top of the page. It says provide catheter care with soap and water to a female resident with an indwelling urinary catheter. Clean the catheter tubing and perineal area only. So we're going to clean the catheter tubing and the peri area. That's it. That's all we're doing. Nothing earth-shattering here. We already know how to read a care plan. We know that every skill starts with the opening and every opening starts with a knock. We know to use a barrier for our supplies. We know to evaluate if we need gloves, and yeah, we will. We know to use a privacy blanket because our patient's uncovered and undressed. We know linen rolls, don't hold them up next to your uniform. We know scoot and roll. If we're going to turn the patient over, we got to scoot them toward us first. We know washing rules. Whatever we wash, we rinse. Whatever we rinse, we dry. We check the water, they check the water. We know how to clean that basin, rinse, dry, and store. And we know how to do our closing. There's not much here that you need to learn. Okay. But this is a longer skill. If we go back a page, you can see that somebody with your level of experience should be able to complete this in 15 minutes or less. Supplies are located at the bottom of page 159 for you. Takes a lot of supplies to do this skill. So this is just like peri-care with an extra step. And if we just review peri-care real quick, we changed the chucks. We cleaned the peri area top to bottom, never going back up. Whatever we washed, we rinsed. Whatever we rinsed, we dried. And then we turned them over and cleaned the back side, up the middle, cheek, up the middle again. Whatever we wash, we rinse. Whatever we rinse, we dry. And we change that chuck side again. You guys remember peri-care? Catheter care is very similar. We're going to put a chucks under them. There won't be one there, so we're going to put chucks under them. We're going to clean the peri area, just like we did. We're going to clean the tubing. Oops, sorry. We're going to clean the catheter tubing, and we're not going to clean the butt because they're not laying in urine. The urine is in the catheter. So incontinent peri-care, we have to clean the butt because they were laying in urine. Catheter care, you don't have to clean the butt. We got to clean the tube instead. Okay, good. So catheter care is usually done once a shift. We're going to clean the catheter and the skin around it. CNAs also inspect the bag and the tubing to make sure it's not near the floor and not kinked. This is a big part of catheter care, is looking at the bag and the tubing. We don't want that bag on the floor. What's on the floor? Yeah, pathogens, germs. We don't want that bag to be on the floor. So that's important. Take a look at the bag. Make sure it's not resting on the floor. You also want to look at that tubing. Tubing should not be coiled near the floor. Your feet can get caught up in it and you'll accidentally pull the catheter out. It happens all the time. You don't want to lift that bag above the level of the patient's hips because that urine will run right back into the patient. And I don't know about you, but I don't need recycled urine. Thank you. Should be a one-way only trip. So don't lift that bag above their hips. If you've ever watched any medical shows online or on, cable or whatever, a lot of medical shows will have somebody walking a patient down a hallway holding their catheter bag like this. You know where that urine is going? Right back in. Yeah, that's pretty gross. Don't do that. So let's talk about the catheter parts. So catheters are nothing more than straws. That's it. It's all your that's all the catheter is. Just like this. I got a straw right here, right? And the straw has a hole and it lets fluid through it. That's all a catheter is. Now, if I were to try to put this into someone, this open area right here, this, the opening would be kind of hard to put in because it's an opening. If I closed it off, it would be easier to insert. So a catheter has the top of it closed and we put the holes on the sides just to make it go in. But all it is a straw. It is no different than this. No different. Okay. And that's what you see here. We close the tip just to make it easier to put in and put the holes on the sides. Good? Everybody good with that? Okay, and then you got the length of the catheter. They're all the same. There's no male catheters, female catheter. They're all the same. You've got the length of the straw. And then down here, we have a place for that straw to connect to something else. Because a straw by itself is just going to let the urine out everywhere. That's not going to be helpful. We want the urine to be collected in something. So we have to have a way to connect that something to the straw. Now, sometimes you'll have this, sometimes you won't. It depends on whether this catheter needs to be left in. It's a straw. It's kind of floppy. It's oh, no problem, Tanya. Come in when you can. So it depends on the use of the catheter. Okay. If I have a catheter that I want to stay in the patient, I want to put it there and make it stay, then I have to have a way that that catheter stays in place because it's just a floppy straw. It's just a floppy straw. If I put this in something and don't have any way to hold it in, it's just going to fall right out. If you put an earring in and don't put a back on it, what happens to the earring? Falls out. Make sense? So if the catheter has to stay in, we got to have a way to make it stay. Now, if the catheter doesn't need to stay in, if all we want to do is put this in to let all the urine in the bladder escape and then take it right back out, we're not leaving it in. This is called an intermittent cath. We put it in when we need to empty the bladder, take it out. Doesn't stay. We would use one of these. It's a straw, an opening and an opening, and the urine just goes straight through. But if I put this in and let go, that's what happens. Doesn't help if it needs to stay. So we created catheters with door stops. That's all it is. So if I put this in and I want it to stay, I use sterile water and blow up a little balloon. And it stays right where it's supposed to go. And it will stay there until it's time to take it out. Now, catheters can be left in place for up to 30 days before they have to be changed. And if I want to take it out, well, I certainly don't want to pull on it because, ow. So in order to take that catheter out, we just take the water out of the balloon. And then, just like the other one, it'll fall right out. Good? Makes sense? Okay. But all they are straws. Now, so you have the catheter with a hole that we're going to attach to a collection device. This other port is how we put water into the balloon and take water out of the balloon. That's why sometimes you'll have this port and sometimes you won't. There are different sizes of catheters. The lengths are all the same, but the size, the diameter of the catheter, there are different ones. And it's a kind of a one size fits most philosophy, but not all. So if we put a catheter in and the patient is leaking around that catheter, we know it's not big enough. So we need something that's going to fit snug in that urethra. Snug, not tight, snug. So when we attach a bag, this port would be plugged into the catheter. Urine's going to go through the tubing and collect in the bag. Bag is going to have markings. We don't care about those. We don't use them. And it's going to have a port to empty the bag. Okay. Nurses put catheters in. Nurses take catheters out, but you can be trained to take them out. Nurses change the bag, but you can be trained to change the bag. CNAs empty the bag. So if you notice, most of our work is down here, not up here. If we're going to work up here, we need more training. Good? Make sense? Not too hard, right? Okay. So the catheter and the bag are two separate pieces, and that's because the catheter can stay in place up to 30 days, but that bag is going to need to be changed about once a week. Okay, so the catheter can stay in place 30 days, bag needs to be changed about once a week, or as directed by your care plan. Do you remember me saying that healthcare is not free? Patients pay for it? You guys remember that? All right. So patients have to pay for this, especially if they're in their home. And there's a lot of people in their home that have catheters. And if you're doing home care on patients with catheters and bedside bags, they may not change these out every week because they're expensive. So we always go by our care plan. And the nurse would address that. Good? Okay, so CNAs are responsible for cleaning the catheters and emptying the bags. Anything other than those two things, cleaning the outside of the catheter and emptying the bag, anything other than that would require additional training that you would get on the job. You guys remember this? Class 2, we talked about infection control, portals of entry, portals of exit, all of that. Okay, when we're talking about catheters, this becomes a huge deal because catheters are responsible for about thousands of deaths a year. Thousands. So these things are pretty dangerous. Pretty dangerous. And that's because if this catheter gives our patient a urinary tract infection, we actually have a word for it. It's called catheter acquired urinary tract infection. For short, we call them CAUTI. C-A-U-T-I. CAUTI. So if we have a catheter acquired urinary tract infection, your patient is already fighting something else. So their immune system is busy. You guys remember that? But this infection is overwhelming and sudden. So the patient doesn't have time to mount a defense. And let me show you how that happens. So we're going to review the urinary system. We learned this last week, but it's been a long weekend. So let's review. We have 2 kidneys. Those kidneys filter blood, produce urine 24 hours a day. That urine drips down tubes called ureters, drip, 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 down tubes into the bladder. And the bladder is going to collect that urine by keeping the valve at the bottom closed. Remember? You go to the bathroom, you open the valve, the urine comes out, you close the valve, and you go about your day. This is all inside you. And everybody's urinary system is the same. Male, female, it's all the same. What's different is the length of the urethra. In female, it's about as long as your pinky. In males, it has to go through the entire penile tissue, so it's longer. All right, when we put a catheter in, that system still works, still exactly the same. Nothing has changed here other than we took a straw, we put it through the urethra up into the bladder. We blew up our balloon to keep it there. And do you see where that balloon is going to land? That's going to hold the valve open. That's all we're doing. We put a doorstop in the urethra. We're holding the door open. That's all we're doing here, is holding the door open. So we made them incontinent. Remember, that's what was broken with incontinent people. We made them temporarily incontinent. And instead, that urine isn't just going to come out of the body. We're going to direct it through a tube to control it. So we made them temporarily incontinent, but we're directing the flow of urine through a tube. Good? Questions? Do you guys understand what this does? So it goes in flat like this. Once we get it in place, we blow up that balloon and it stays there. We're ready to take it out. We take the water out of the balloon and it just slides right out. Questions so far? Okay. So this is where it gets interesting. This is why this is so dangerous for patients. So we have a catheter in the bladder. The balloon is inflated. We're holding the valve open and the catheter is extending out of the body. The urine is coming down through the tubing and into the bag. This is a closed system. Okay. No openings here. No way for bacteria to get in. Unless we decide to empty it. When we empty this bag, this is the one place that bacteria can enter. And who empties the bag? We do. So that's important for us to remember. Okay, we don't want bacteria in the bag. It's a closed system. Bacteria can't get in unless we allow the bacteria in. So when we have a catheter in the bladder, holding the valve open, the tube is directing the urine out. It's going to be attached to some sort of a bag. Now, there's lots of different bags. This is a bigger one, holds more urine. We usually use it when the patient's in the hospital or overnight or not moving around too much. It's a suitcase of urine. But if your patient is out in the community, ambulatory, if they're shopping at Walmart, nobody wants to carry a suitcase of urine around with them at Walmart. It's embarrassing. People will look. Nobody wants that. So we created a more discreet option, which is a small bag called a leg bag. Now, leg bags, they're smaller. They're going to hold less urine, so they're going to need to be emptied out more frequently. But they'll attach to the inside of the thigh or sometimes the inside of the calf using elastic bands. So the catheter gets attached to the leg bag. The leg bag collects urine. And then the patient goes to the bathroom, opens a little valve, and empties the urine into the toilet. You guys see how catheters work? Nothing scary here. There's nothing scary about catheters. Right. Well, yes, most of the time your patients with a leg bag will do it themselves. But there are times that CNAs may have to empty the leg bag. It is the valve it's hard to kind of twist and it is a little bit more challenging. Usually these are used by people who can manage them themselves, but sometimes CNAs may be helping with a leg bag. It's just a twist valve at the bottom. Okay, so here's the problem. When we empty these bags, doesn't matter what bag we're emptying, when we empty the bag, if we allow bacteria into this bag, there's nothing there to stop it. Remember in our body, we've got some white blood cells that are there to help prevent infections. Well, inside your urethra, you got a whole bunch of white blood cells that are just kind of hanging out waiting for an invasion. They're bouncers. They're just kind of hanging and waiting. And if a bacteria should wander in, those white blood cells will get rid of it before it ever causes a problem. Now, this works well as long as there isn't a busload of bacteria that shows up all at once. That's why we have to wipe away from the urethra. Good. Now, the problem here is that with a catheter, those white blood cells are stuck on the outside of the catheter. And if we have bacteria on the inside of the catheter, it's a secret tunnel. So when we allow pathogens into the bag, they start to multiply. Pathogens don't need little girl pathogens and little boy pathogens to make baby pathogens. They don't need that. Pathogens, particularly bacteria, need two things: the right environment and the right food, enzymes, to procreate. And once it gets in the right environment, it just zips itself in half, and now we got two. Well, wouldn't that be easier, right? So it eats the food it needs to eat in the right conditions, and it just creates a clone. Those two will repeat the process. So we started with 1, now we got 2, 2 become 4, 8, 16, 32, 64, 128, 256, 512, 1064, and it doesn't take long to realize that this is going to get overwhelming real quick.
Are UTIs like easier to get with pathogens?
Absolutely. So, and they're much, much, much more dangerous with a catheter. So if we've got bacteria in here and they start to multiply, they're going to run out of room. So they start to climb, and now they get fresher food. So they really ramp up, and they're multiplying, and they're climbing, and they're climbing, and they're climbing, and they're climbing. And now they get into the catheter. Really fresh food, really warm urine, and we're now blocking out light. So those trillions of bacteria become quadrillions of bacteria. And they climb and they climb and they climb. And your bouncers, your white blood cells, have no idea they're there because they're in the secret tunnel inside the catheter. So when they jump out at the top of the catheter, which is inside the bladder, when those bacteria jump out, it is an overwhelming infection in a very short amount of time on a patient who has an immune system that is otherwise busy. This can kill your patients. Make sense? This requires good attention to detail because urinary tract infections caused from catheters kill thousands of people a year. And it's because the bacteria are able to enter the bladder without any mitigating forces at all. They're just allowed to multiply. Okay. So there's 3 points that we can allow bacteria into the system. There's way up here. This is inside the bladder. We're not inside the bladder. So this isn't really us. We're not going to let bacteria into the system here. But if the nurse is putting the catheter in and they don't maintain sterile technique, yep, they'll introduce bacteria. So this is the nurse, not us. Down here, we don't do this. We don't change the bag out without additional training. So this could be us, but not right now. And what do you think that additional training is going to include?
Putting the catheter in.
Well, it's going to include attaching the bag while not introducing bacteria or sterile technique. Okay. And then we get all the way down here, emptying the bag. Oh, wait, that is us. So we need to be super careful when we are emptying the bag, and this is a tested skill. When we are emptying this bag, that this port doesn't touch anything. Nothing. Nothing. Not your gloves, not the bed, not the cup, not the bag, nothing. That port has to remain clean. Now, we used to wipe the port off with alcohol after we emptied the urine. But what we found, we thought we were doing a good job, right? No bacteria. We want to kill the bacteria. Good job. Alcohol. That's what we need to use. Well, they did some studies and they realized that this port, this plastic, right, is a polymer. And when you clean it off with alcohol, chemicals always react. No, it actually doesn't melt. What it does is it dries out this plastic. It removes the moisture, evaporates the moisture out of it, and it makes it dry and little micro cracks form. It leaves it open for micro cracks. Well, if we have micro cracks, those are great places for bacteria to kind of hang out in. So we found that that's not, we actually grew more when we use the alcohol. So sometimes we have good ideas and we don't realize they're really not good ideas until we test them. So some videos out there you'll see still use alcohol, and that's okay for the video. But what do we use as our holy Bible of what to do? The care plan. So if the care plan does not tell us to use alcohol, are we using alcohol? Okay. So remember, there's 3 entry points where bacteria can enter. It's a closed system otherwise. So we've got to be careful if we're going to be around any one of those 3 entry points. Urine bags should never hang on the floor, should always be above the floor. The tubing should never be coiled near the floor, and you should never raise the catheter bag above the level of the patient's hips. If the catheter comes out, patients will pull catheters out, particularly confused patients, because it doesn't belong. It's not supposed to be there. Catheters shouldn't be painful, but they are uncomfortable. We have to have a catheter big enough to take up most of the room in the urethra to prevent leakage. So when we put this in, it's got to be a really snug fit so that there's no leakage around it. Well, that's a little uncomfortable, right? We don't normally have something there. It feels weird. And a lot of times people will tug on it to remove it. The only thing that's holding it in is that little balloon at the top. So if you tug on it hard enough, it's going to come out. So, but you've got a balloon, if it comes out, you got a balloon this big going through an opening this big. You're going to get tissue tearing. So you'll see a little blood, maybe a little mucus, and probably, definitely urine. But, and your patient will probably say, ow, that hurt. Okay, it's not life-threatening. They're going to be fine, but it is going to tear that tissue. Now, anytime we have injury, we always have swelling. Always. Is this an area where we want swelling? No. And if the swelling gets too bad, I'm not going to be able to put another catheter in. So if a catheter comes out, you need to let the nurse know now, because I've only got about 30 to 40 minutes to make a decision. After that, the swelling will be too bad. I won't be able to get a catheter in, even if we need one. So this is not go to lunch, take your break, do your rounds, and then let the nurse know. This is when you notice it, let the nurse know. That gives them options. Good? So sometimes patients pull them out. But believe it or not, patients are not the people that pull the most catheters out. CNAs are. CNAs pull, even experienced CNAs. CNAs pull catheters out all the time. Because if that patient is laying in bed and you got to roll them away from you, if you're leaning against that bed and that catheter is there, trapped between your leg and the mattress, you will roll them right. That catheter will come right out.
Is there a way for you to like you're changing them or whatever you like, or for instance, like you said, to like maybe kind of pull it out, but not all the way that
Sure.
cause them to be pulling on it?
Absolutely. This balloon, it's water, so it compresses, right? So we can move it halfway down the ureter and it can kind of stick there, and boy, that would be uncomfortable. And yeah, if it's uncomfortable, what are you going to do? Yeah, you're going to pull it out. That's what a patient will do, because it doesn't belong. Okay, so we've got to be careful when we're CNAs. Getting a patient out of a bed into a chair, if you don't pay attention to the fact that they have a catheter and it's on the other side of the bed, when you transfer them, it'll come right out. Absolutely. CNAs pull out way more because we do more with the patient. We're rolling them in bed. We're getting them out of bed. We take them for walks. We are doing things with the patient. If we don't pay attention to this, that catheter will come out. If this is the number one way catheters come out, by the way, from CNAs, is we get our feet stuck in the tubing because it's clear and pull it right out. This happens all the time, all the time. So we need to be aware of this and make sure the tubing is coiled on the bed, not near the floor. If we're going to transfer a patient or turn them over or move them in any way, check for a catheter first. Make sure that catheter goes with you, not against you. This happens way more than you would believe. Patients get up and walk, that catheter bag was on the bed, and they walk right out of that catheter. That's our fault, not the patient's. That's our fault because we didn't bring the bag with the patient. Remember, it's attached. Good. So if you're not a person that has good attention to detail and you want to work in a hospital, this is going to be problematic for you, because if this patient has to walk somewhere in the hospital and they're attached to a catheter and an IV pole, your job is to make sure all of that stuff goes with them. So if you're not really big on attention to detail, that hospital setting is not the right place for you, because there's a lot going on. It's not just walking a patient. It's walking a patient and everything attached to them. Okay, good. All right, if the catheter comes out, number one thing you have to remember is don't panic. Your patient is fine. They are absolutely fine. You'll see a little blood, yes. It's going to hurt and sting, yes, but they are fine. It's like, you know, cutting your hand. Yeah, yeah, thank you. I can't say it, but yes, it does. But you're not going to die. You're okay. Don't pay. Your patient will take their cues from you. If you're like, oh my God, what do I do now? Whoa, don't do that. Right? We're going to remain calm. We don't throw the catheter or the bag away. And this is super important, because as the nurse, I have to inspect this system. If the balloon comes out and it's still filled with water and it looks like this is something I can deal with. This is a nurse problem. If it looks like this after it comes out, this is a doctor problem, because I'm going to inspect this and I'm going to see that there is a piece of that balloon missing. So where is the piece of that balloon? In the patient. And that will cause a reaction in the patient because it is a foreign object. So we literally have a scope that we put up there and go fishing in some cases. So we want to be aware of what kind of problem we're dealing with. The only way as a nurse to be aware of the kind of problem is for me to inspect it. Well, if you threw it away and it's in the soiled utility room with 1,000 other things, how am I going to be able to see what kind of a problem I've got? Good. So we don't throw them away. What we do is we get a regular trash bag out of the bottom of your trash cans. There's always extra trash bags in the bottom of the trash cans. Grab one of those, put the bag and the catheter, the whole thing together in that bag, put it in the bathroom, and then go let the nurse know catheter came out. The bag and catheter are in the bathroom for your inspection. And that becomes their problem. It would be a much bigger problem if you don't save this. Good? Make sense? Let the nurse know right away. So there's a couple different types of catheters. This is a straight cath or intermittent cath. It's also called a red Robinson. It's red. Notice only one. It's just a plain straw. Just a plain straw. This goes in, urine comes out. So you probably ought to have this like hanging over something. This goes in, urine comes out. If we want to keep a catheter in, we're going to use something like this. Put it in and inflate the balloon, inflate the ball. This is called an indwelling or Foley catheter. So Red Robinson, Foley. Everything is named for the people that invented them. So a couple different types of catheters. And then we've got this one down here. This is called a Texas catheter or a condom catheter because it goes on just like a condom. It's sticky on the inside. We roll it down the shaft, and it has this little tip here that connects to the bag. So it's an external catheter. This is only for men. It needs to be changed every 3 days. It stays in place, but it directs the urine away from the body, but nothing internal. So we've reduced the risk of infection because we didn't allow bacteria to hide. We reduced the risk of infection, and we're able to direct the urine away from the body so we don't have those incontinence skin issues. But there is a problem with this. This reservoir tip right here is going to allow some urine to stay right up against the tip of the penis for 3 days. What do we know about adult urine? It's acidic. It's going to eat that skin. So when we change this out, really, really good male pericare is required. I mean, we want to get it clean. And then we're probably our care plan is probably going to have us use these little pads. They look like alcohol pads. And you just wipe the pad on the tip. And it's called skin prep. And it provides a barrier. It's like putting an extra layer of skin on there to help reduce that acid contact against the skin. No, you'll see them in all kinds of settings. We actually use them quite a bit. But yeah, you will see them. Well, these are used not, I shouldn't tell you this. These aren't just used for patients. You put this with a leg bag. Remember that leg bag we saw earlier? Right? And have you guys ever been to like a pro football game? There are people in the stands of a pro game with one of these and a leg bag on so they don't have to go to the bathroom and they can watch the game. No interruptions. You got to be a diehard fan to do that, but yes, that does, yeah. You can actually order these. They're non-medical. You can order these on Amazon.
So when would you use like the common catheter versus like the one that actually goes?
When the care plan tells you to. I know you weren't expecting that one. So you're talking about from a nursing standpoint. So this is going to be decided on by the doctor. This is a doctor's order. Nurses influence this. So if I've got a patient who is incontinent, okay, let's say I have an older male patient who's incontinent. He's a little confused. And he's got a huge wound on his backside. He's incontinent. I don't want the urine against that wound. He's confused, so I don't want to put an indwelling catheter in because he's going to pull it out. So the best way to manage the urine coming out of his body would be through a condom cath.
So there's no real drastic difference besides the fact that it's on the outside.
Right. It does the same thing, but reduces the risk of infections and reduces the irritation. Right. They'll still pull at this occasionally, but this seems to be better tolerated with your confused male patients. Now there's something that we're now using for females, somewhat new. And I put that there. You guys can take a look at the catheters and the balloons and the bags. So go ahead and pass this around. There's something that we're using for females that's kind of an external urine management system as well. So instead of putting a catheter in. So if we have an incontinent female patient who is in bed, there's something called a PureWick that we're using. And your book actually does talk about it on page, sorry, let me just borrow this real quick. Uh, 155. And it's basically a suction system. Okay, it's like think of a tampon, okay, but lay it down and attach it to suction. So as the urine comes out of the body, the suction pulls it through the cotton and away from the body. So you don't have as many skin issues. So we use those a lot when we have patients with wounds. because you never want, it's a bad idea to have urine up next to an open wound. Just a really bad idea. So these are just ways of managing the urine if our patient is incontinent. So does that make sense? Good. So when we're doing catheter care, we just hold the catheter and do pericare. So we don't want to pull on that catheter. I mean, the only thing it's holding in is a little balloon. If you pull hard enough, it's going to come out. So let's hold it in place as we're cleaning the areas just to make sure it doesn't get pulled out accidentally. So we're just going to hold that catheter up and we're going to wipe the peri area, the skin. So middle, side, skin fold, skin fold. We've done that. We know this. This is pericare. We've done that. Just hold the catheter up out of the way. Anything we wash, we rinse. Anything we rinse, we dry. We know this as well. And then we're going to clean the catheter itself. So I'll hold the catheter where it exits the body, and I'm going to wipe down the tubing away from the body. Never wipe toward the body. If you wipe toward the body, you're bringing bacteria. So we're going to start where the tubing exits the body and just clean the tubing away from the body. This prevents bacteria and stuff from accumulating on that tubing and being able to potentially enter the urethra. So catheter care is cleaning the skin around the catheter and cleaning the catheter tubing. It doesn't matter which one you do first. You can clean the skin first. You can clean the tubing first. Whatever you want to do. No, there's no right or wrong way. Okay. Good. Okay. So our care plan tells us to provide catheter care with soap and water. So what are we using? Soap and water. Please don't use alcohol. And yes, that happens during the exam. Does our care plan say? And what do we do with the care plan? Are you starting to see how easy this test really is? The care plan tells you what to do. As long as you do what the care plan tells you what to do, and you've learned how to do it with our principles, you can't fail the test. It's impossible. Do what the care plan says, do it this way, and you've got it right every time. Good. Says clean the catheter tubing in the perineal area only. So are we cleaning the butt? Why? Care plan. So going through the steps, we're going to do our opening. Knock, knock, knock. Hi, Miss Jones. My name is Patty. I'm your CNA today. I'm here to clean your catheter. Is that okay? Close curtain, wash hands, get a barrier, get our supplies, and then we're going to go get the water. Use paper towel to turn the water on. Check the temperature. It should feel warm, not hot, not cold, just warm. Who else checks it? Patient. Absolutely. We're going to use a privacy blanket for this skill because our patient is uncovered. We definitely want to put some gloves on because of where we're at. We're in their private area. And the first thing those gloves should touch is the patient. We're going to scoot them toward us, roll them on their side so we can put that chucks underneath them. Remember, clean rolls toward us. We'll put the chucks underneath them. We're going to roll that privacy blanket up to their waist, just like we did with pericare, and cover their legs with a towel. Once we do that, we're going to wring out our washcloth. We're going to soap 5 leaves. Sorry, soap 5 leaves. When we soap 5 leaves, we're going to hold the catheter and wipe down the middle, outside, outside, skin fold, skin fold. And then we'll put that aside, get another washcloth, wring it out, and rinse. Middle, side, side, skin fold, skin fold. And then we'll put that to the side and dry. And then we'll get another washcloth. We're going to soak 4 leaves this time, 5 for the skin, 4 for the catheter. If you want to make it easy, wipe it 5 times. If you want to just do 5, it's fine. As long as that catheter gets wiped, it doesn't matter whether it's 4 times or 5 times, whatever you want. And then we're going to clean the catheter, holding it where it exits the body, wiping away from the catheter with all 4 strokes. Put that aside, and we're going to rinse. All 4 strokes, put that aside, and we're going to dry. We'll cover the patient up. We're going to turn them back on their side to take that chucks away. Remember, we don't want to leave a chucks under a patient that doesn't need one. And then we're going to leave the patient on the center of the bed, covered with the privacy blanket while we put everything away. So we'll dispose of our soiled washcloths and towels. We're going to clean, dry, and store our basins, and then take our gloves off. Once we've taken our gloves off, we can remove that privacy blanket and do our closing. Easy. This is a longer skill, 15 minutes for this skill. Is a longer skill. Not quite as bad as partial bed bath. That was 19. And these are your important steps that we just went over. Now, before I show you that video, I'm going to talk to you about drainage bag because I want to show these videos back to back. They're 2 separate skills, but I want to show the videos back to back because it makes sense. When we do catheter care, generally speaking, we're going to be emptying the drainage bag. For the test, 2 separate skills, but in reality, they're going to be done together. Okay, so these are our steps. Not as many steps involved in this. Somebody with your level of experience should be able to do this in 9 minutes or less. You're just emptying the bag. It doesn't take 9 minutes. This is overly generous. I mean, like really generous. It is a mannequin skill. You've got the steps there. There's a video on it. And the care plan at the top of page 165 says to empty the resident's urinary drainage bag into a graduate container and measure and record the urinary output in mLs or cc's on the intake and output form. You can see the intake and output form here. You can also see it on page 169 of your book. All of your supplies are at the bottom of the page. And we talked about the bags already, but let's review. We've got the big bedside drainage bag. We've got a small leg bag. They both attach to the catheter at the same point. Doesn't matter which one of these you use, they attach to the catheter the same way. So the only thing that's different on these 2 bags is where they live, how much they hold, and how we empty them. So bedside bag is going to live on the side of the bed, just like the name implies. A leg bag is going to live on the leg, just like the name implies. How much they hold? Bedside bags will hold a lot, 2 liters of urine. It's a lot of urine. So usually we're only emptying this once every shift. If we're working a 12-hour shift, once a shift, usually, unless it's getting really full. Patients on a diuretic and we're trying to pull fluid off of them. These are smaller. They usually only hold about 750 cc's, which, so that, can you hold up your bottle real quick? That's 500, just over 500 cc's. Was it 550? 591. Okay. So right about, well, close to 600 cc's, right? This holds 750. So not much more than that. For comparison, that's 500. Your water bottle is 500 cc's. So a little bit, 1.5 of those. That's all it's going to hold. So this guy's going to have to empty his bag a whole lot more. So that's a big difference, how much they hold. How we empty them is also different. This one is going to go to the bathroom, just any bathroom. Take a bathroom, find a toilet, aim this over the toilet, and twist it open. The stream comes out into the toilet. Patients usually do this themselves. This one is a little more complex. This has a port with a T-valve that has to be pushed, and that's what we're going to empty it. This is usually done by CNAs. Okay, so there's no difference with how they attach to the catheter. The only difference here is where they live, how much they hold, and how they're emptied. Yes, sometimes. If your patient is out of bed going to activities and participating in maybe therapy or going on excursions or whatever, then yes, you will have leg bags. Remember that everybody in a nursing home is not restricted to bed. Some people in nursing homes are very active. They're there for nursing care. What kind of care is nursing care?
Daily activities.
Actually, that's not nursing care, believe it or not. That's a
Oh,
that's a yeah, well, that's a common misconception. So yeah, so good. Hold time out real quick. Let's talk about nursing care versus personal care real quick, right? How many of you guys brush your own teeth? Are you nurses? How many of you guys bathe yourselves? Are you nurses? How many of you guys have ever bathed a child? Are you a nurse? Bathing, dressing, grooming, toileting, feeding, mobility, those are all things you do for yourselves every day and does not require a nurse.
I was thinking you said CNA.
Yeah, so that's why we file it under personal care. And that's what CNAs help our patients with is personal care. But that is not nursing. So this is something that a lot of CNAs struggle with in their mind is if they have somebody who requires a lot of personal care, they think that is a lot of nursing care. It's not. This lady here has no nursing care at all, but she has to have all personal care done. She doesn't need to be in a nursing home because what's done in nursing homes? Personal care and nursing care. Nursing homes require the patient to need nursing care. Personal care can happen anywhere. Assisted living, home, private homes, nursing homes too, but personal care can happen anywhere. So in order to have a bed in a nursing home, the patient has to have a need for nursing services. So what's a nursing service? Well, medications is one of them. If the patient can't manage their own medications, that would be one. Wound care is a nursing service. Tube feedings is a nursing service. But the biggest nursing service that is offered is assessment. Keeping track of how the patient is doing and noticing any issues quickly and developing a plan for those issues. So nursing is mostly mental, not physical. Personal care is physical. Who does that? CNAs. So as far as nursing goes, assessment and planning makes up 90% of the nurse's job. So if we have patients that require frequent assessments, they need a nurse. Does that make sense? Good. So when you see nurses sitting at a nurse's station and you think to yourself, oh my gosh, they're not nursing, they're not doing nursing stuff. 90% of nursing is mental thinking. Good? Make sense? So what's the difference between an LPN and an RN? LPNs are the ones that do. RNs are the ones that think. So medications and wound care are often done by the LPN. And the RN is there to plan the care. Good? Make judgments. All right. That will help you as you're trying to think of your way through, your steps. What's your next step? Okay. And when I was an LPN, I did not know that. I had no idea. I thought I did everything an RN did. Because I was just looking at the doing part. What's 90% of nursing? Thinking. But when you're doing and you're not trained to think, you don't know that part. It wasn't until I got into nursing school and, oh, I got to think. I didn't sign up for that. All right. So when we empty the drainage bag, we're going to place a graduate container on a barrier on the floor. We can't do this on the table because remember, we can't ever lift that bag up above the level of the patient's hips. So this is all on the floor. But you can't put a urine cup directly on the floor. That's just gross. So we're going to put a barrier on the floor and then put the cup on the barrier. Good. Let me show you what this cup looks like. Oh, where is my cup? Okay. All toileting items go in the bottom drawer. It's kind of like a person. These drawer systems are made up like a person, like grooming, top drawer, bathing, middle drawer, toileting, bottom drawer. This is a triangular graduate, because it has markings, container. It's got a big name, but all it is a measuring cup. It has markings for ounces and cc's. Which ones do we use? Cc's. So ignore the ounce side. We're going to round this to the nearest line. Doesn't matter whether it's up or down, whatever is nearest. We're going to round to the nearest line. So if you look at these cc markings here, pull it up to the camera so you guys can see at home too. So if you look at these cc markings here, you can see the line for 150, and then there's a small line. A line for 200 and a small line. A line for 250 and a small line. A line for 300 and a small line. Remember, we're not paying attention to the ounces. Get rid of the ounces. So these small lines are 25s. So if this is the line for 200, there's 225 and 250. 275 and 300, 325, 350, 375, 400, and so on. And we're just going to round to the nearest line. So I'll let you guys pass that around. The nearest line. Up or down, doesn't matter. Doesn't matter. For the test, you can be 50 cc's off in either direction from the evaluator's measurement. So either way. So when we empty the drainage bag, we don't want that port to touch anything. We talked about that. It can't touch the cup. It can't touch your gloves. It can't touch the bed. It can't touch the bag. It can't touch anything. So that port on the bag, on the drainage bag, is usually a T valve. So when you take it out of its house, it's got this little T thing and it slides to the side. So you just slide the valve open, let all the urine out, and then you slide it closed. Can you bring me that bag real quick? Thanks. Thank you. Oh, thank you. So if we have this bag here, and this is attached to the catheter on the patient way up there, wherever. So we're going to just kind of get that out of the way. And I'm going to empty the bag. This is my port right here. It's got a little house that it lives in. I'm going to take it out of its house without letting it touch anything. And I need to slide this to the side to open it. Right now it's closed. Can you guys see that? It's closed. When I slide this to the side, I'm not touching up there. You see that I'm not touching the end of the port. I'm sliding it to the side and that opens it. Okay, now it's open. I'm going to put it over the cup and the urine's going to empty out. When the urine is done, and it doesn't have to, like, you don't have to get every single drop. It's not Maxwell House, good to the last drop. Okay, you just empty it. When it's empty, you're going to slide this T valve closed. You don't want to leave it open. Pathogens can get in. So we're going to slide that closed without touching the end of the port. So one of the big mistakes people make is doing something like this. What am I touching? Yeah. So you've got to be careful to stay below the T. Always stay below the T, not above it. Now, once I get it closed, I'm going to put it back in its house very carefully. Not like this. very carefully back in its house. Good? Okay. So we empty it into the container, and we have to measure the urine on a barrier, on a flat surface, and at eye level. All three of these are on one checkpoint line. So if you don't have it on a barrier, you don't get credit for any of it. It's like you didn't even do it. If you don't measure it on a flat surface, you don't get credit for any of it. It's like you didn't even do it. So we need it on a barrier, which we have, the chucks. We need it on a flat surface, and we need to do it at eye level. So we can't measure it where it is on the floor, unless you want to like lay down on the floor. And I don't recommend that. So we're going to wrap the chucks around our container, because remember, we can't carry an open container of urine through the room. We're just going to wrap that chucks around the container, take it over to the bathroom, and put it on the lid of the toilet. Now we have it on a barrier, on a flat surface, and we can measure at eye level. No, I don't want it on the counter because it's urine. Well, it's just high on the gross meter. It really shouldn't be on the counter. Yeah. Bedpan. You don't want to dump the rinse water in the, it's just gross. Toileting things really need to stay in the toilet. So we're going to use just the lid of the toilet, put the barrier on there, unwrap it, get down and measure it at eye level. And then we're going to document it. Now, this is your documentation form. Is urine intake or output? Think about it. Is urine intake? Output. Yeah, if you document urine as intake, you are legally swearing that that patient drank urine. That's what you're saying here. If you put it in the wrong box, that's pretty high on my gross meter. I don't know about you, but you don't want to try to defend those actions to a lawyer. So make sure you're getting it in the right box here. So we're going to put the time. Military time is best. If you don't use military time, make sure you use AM or PM. We're going to put the type of output. Urine isn't the only thing that comes out of the human body. Other stuff can come out. You can bleed. Blood can come out. Wound drainage can come out. Respiratory secretions or sputum can come out. You can throw up. That's emesis. That can come out. So we have to indicate what came out. So we're going to write urine there, the amount that we measured, and our initials. This is a documentation skill, so you do have to document. You've got to document correctly. So to do this skill, we're going to follow the care plan. Every skill starts with the opening. Every opening starts with a knock. We're going to put a barrier on the floor, get our triangular graduate container and our gloves, put on our gloves. We're going to open the port, empty the urine into the container. Don't let that port touch anything. Close the port, put it back in its house. Make sure you don't let it touch anything while you get it back in the house. We're going to wrap that container up in the chucks, take it over to the bathroom, put it on the lid of the toilet, unwrap it. We're going to get down at eye level to try to see how much urine is in there. After we do that, we'll pour the urine in the toilet. We're going to rinse it out, put the rinse water in the toilet, and then put our container back where it goes, just like we do with everything else. We'll remove our gloves, do our closing, and document. Now, remember to wash your hands again after you document. Now, I am going to tell you, when I show you this video, you're actually going to get to see a close-up of the urine cup as I'm measuring it. See if you can tell how much is in there. So the first thing we're going to see is the catheter care video, and then I will show you the drainage bag video right after. And then we'll get to the very last skill.
Jones, my name is Patty. I'm your CNA today. How are you? Good. I need to do catheter care. Is that okay? I'm going to close your curtain, wash my hands, get my supplies, and I'll be right back. Okay, Miss Jones, I'm going to gather my supplies. I'll start out with a barrier that provides a clean place to put my supplies. And we're going to get 4 washcloths, a towel, a chucks, a privacy blanket, and now I'll gather my basin and soap. And a set of gloves. All right, Miss Jones, I'll just get some water. I'll be right back. Okay, would you like to check the water temperature and make sure it's okay? It's good? Good. I'll place the washcloths in there to stay warm. And I'm going to cover you with a privacy blanket. This is going to help protect your privacy and keep you warm while we do this skill. And I'm going to pull your sheet down to about your knees. Okay, Miss Jones, I'm going to place this pad underneath you. This is going to help keep your bed dry while we do this skill. First, I'll roll it toward me. And place it on the bed. And then I'll put my gloves on. All right, Miss Jones, can you scoot toward me, please? Thank you. And can you roll onto your left side? 1, 2, 3. Thank you. I'm going to be very careful, making sure that the catheter tubing rolls with the patient and doesn't get pulled on. I'm going to unroll the chucks underneath the patient's hip and have the patient come back onto their back, making sure that they don't lay on that catheter tubing. Miss Jones, can you scoot to the middle of the bed, please? Thank you. Miss Jones, can you scoot toward me? Thank you. And roll up onto your right side. 1, 2, 3. And now I can unroll the chucks to protect the bed. Come on back, Miss Jones, and scoot to the middle of the bed. Thank you very much. Okay, now I'm going to start cleaning the catheter. I'm going to roll your gown up inside the blanket. I will be exposing you, but we'll make this as brief as possible. Please let me know if you're uncomfortable. As I roll the gown in the blanket, I want to make sure that I don't grab the catheter, that we don't cause any unnecessary pulling or stress on that catheter. And now we'll cover her thighs with a towel. This exposes only the area that we're working on. I'm going to take the first washcloth and wring it out and apply soap to 4 leaves. 1, 2, 3, 4. Now I'm going to clean your catheter. I'm going to hold the catheter where it exits the body, wrap the washcloth around, and wipe away from the body. Fold that leaf over. I'm going to hold it, wrap the washcloth around, and wipe away from the body. That's 2. We're going to do this 2 more times. Away from the body. 3. And the last one. 4. I'll set this washcloth aside. Whenever we wash, we must rinse. So I'll wring this washcloth out, and we'll use it to rinse that catheter the same way we washed. I'm going to hold it where it exits the body, wrap the washcloth around, and wipe away from the body. We'll do this 4 times. 2, 3, and 4. Set this aside. Now we'll dry the catheter. Now we're going to do peri-care. We'll take a washcloth out of the basin, wring it out really well, and we're going to soap 5 corners. 1, 2, 3, 4, and the back side is 5. Okay, now I'm going to clean the peri area. I'm going to lift the catheter up out of the way with my pinky and hold the labia open while I clean down the center with the first leaf, always going top to bottom. And then we'll remove the washcloth and fold that leaf over. Now I'm going to clean down one side of the labia, top to bottom, fold that leaf over, clean down the other side of the labia, top to bottom, fold that leaf over. I'm going to clean the skin fold between the groin and the leg, fold that leaf over, and clean the other skin fold between the groin and the leg, and then set that washcloth aside. I'm going to take the final washcloth and wring it out really well, and we're going to rinse all of those areas the same way that we washed them. So I'll hold that catheter out of the way and spread the labia open, cleaning down the center, top to bottom. Fold that leaf over, clean down one side of the labia, fold that leaf over, rinse down the other side of the labia, fold that leaf over. We're going to rinse the skin fold, fold that leaf over, and the other skin fold. Set that aside. Now we'll dry gently by patting dry top to bottom and then removing the towel. Ms. Jones, I'm going to cover you back up. I'll unroll that blanket, which will replace the gown over the patient. I'm going to make sure that the catheter and the tubing is coiled on the bed, not near the floor and not where the patient is laying on it, making sure it's not kinked. Ms. Jones, I'll be right back. I need to dispose of your supplies. The towels and washcloth will be placed in dirty linen. The basin is going to be clean the way we clean everything else. We'll return the basin to the drawer, and on the way we'll pick up the soap. We'll open the drawer with the paper towel and return the basin to its storage area. Now I'll dispose of my paper towels. Okay, Ms. Jones, I need to remove the chucks from under you. Can I get you to scoot toward me, please? Thank you. And can I get you to roll up on your left side? 1, 2, 3. Thank you. I'll roll this soiled chucks toward the patient and tuck it under her hip. Come on back, Ms. Jones. And scoot back to the middle, making sure the patient is not laying on that catheter tubing. Okay, Ms. Jones, can you scoot toward me again, please? Thank you. And roll up on your right side. And I'm going to remove that chucks from the bed. Okay, you can scoot back to the middle. Thank you. This is going to be thrown away. Okay, Ms. Jones, let me just look at your catheter one last time. Make sure that the catheter tubing is coiled on the bed, that the catheter is not on the floor. Everything looks good. I'm going to remove the chucks from the table, and we're going to throw this away, and then I'll remove my gloves. We'll throw those away. Okay, Ms. Jones, I'll pull your sheet up now. And I'll remove the blanket as I do so, rolling it into a ball. You put this in dirty linen. Okay, Ms. Jones, here's your call light. If you should need anything, just let me know. Are you comfortable? Can I get you anything while I'm here, like a magazine? I'm just going to open your curtain and wash my hands. After washing my hands, I'll think about the steps of my skill, make any corrections that need to be made, and then tell the evaluator my skill is done.
right, any questions on that one? Turn around real quick before. Any questions on that one?
What would we document in that?
You're going to document according to your facility policy. So a lot of places don't have CNAs document tasks that are done. It's just a checklist. Most of the time in most settings, CNAs document numbers. There's no numbers here. So the next skill will require documentation.
Hello, Miss Jones. My name is Patty. I'm your CNA today. How are you? Great. I need to empty your urinary drainage bag. Is that okay? Okay, I'm going to close your curtain, wash my hands, get my supplies, and I'll be right back. For this skill, I'll need a barrier, which I'll place on the floor under the drainage bag. I'm going to need a set of gloves. And I'm going to need a triangular graduate container. I want to inspect the catheter tubing to make sure that it's coiled on the bed and the patient isn't lying on it and it's not kinked, but also that it's not hanging near the floor where somebody might get their feet tangled up in it and trip or accidentally rip the catheter out. This catheter looks like it's in the appropriate position. We'll now remove the port from its protective sleeve on the bag. Sliding the valve to the side will open the port. We can now position this open port over the graduated container and tilt the bag slightly to the side to allow the contents to drain into the graduated container. While doing so, we want to be careful not to allow that port to touch any other surface. Once the urine bag has been emptied, we'll slide the port back to the side to close it and very carefully insert it back into its protective sleeve. We want to make sure that the bag is hanging on a non-movable part of the bed and it's not touching the floor. We can now fold the chucks over the graduate container for safe and secure transport to the patient's bathroom. Once we're at the patient's bathroom, we're going to set the graduate container down on a barrier on a flat surface and position it so that we can read it. We need to be at eye level, and we're going to round to the nearest line, either up or down. You can see that the urine in this container is nearest to the mark of 425, so the amount that we will document is 425 milliliters or cc's. Once we've measured it on a barrier on a flat surface at eye level, we can now empty the urinary graduate container. We'll throw the barrier away, open up the toilet, and we're going to dump the contents of the graduate container into the toilet. Now we're going to rinse the graduate container. We'll deposit the rinse water into the toilet as well. Now we can clean. After dumping the rinse water into the toilet, we'll set it down, use a paper towel to pick it up, paper towel to dry the outside, a paper towel to dry the inside, and we'll discard this, and then one for the drawer. We're going to place the graduate container in the bottom drawer and close the drawer with a paper towel. Okay, now I'll throw the paper towels away and remove my gloves. We'll throw those away as well. Thank you very much, Miss Jones. Is there anything else I can get for you while I'm here? A magazine, perhaps? You have your call light there. If you should need anything at all, please feel free to let me know. I'm going to open your curtain, wash my hands, and document my skill. Thank you. After washing my hands, I'll document on the intake and output sheet that the evaluator gives me. I'm going to document the time of output, the type of output, which is urine, the amount of output in cc's, and my initials. After documenting, I'll review the steps of my skill, make any corrections, and then tell the evaluator my skill is done.
Okay, any questions? Any questions on that one? Okay, were you able to see how to measure? Okay. Remember, closest line, up or down, doesn't matter. Just closest line. Okay, so we're going to disregard this for a second. And we're going to go all the way back to class 2 because there was a skill that I did not get to. It's another range of motion skill. And we already know range of motion, but I do want to show you this particular one just so that everything is covered. So if you go to page 76 in your book, we have range of motion shoulder. So there's nothing new to learn here. It's just rehashing the range of motion movements that we've learned in the past. So nothing earth-shattering here. If you look on page 77, you'll see the care plan at the top of the page. It tells you your patient is lying in bed for this skill. Provide the following range of motion exercises to the residents. Is it the right shoulder? Left. Okay, the resident's left shoulder, flexion, extension, and abduction, adduction. So if you remember, we went through this a couple of weeks ago. Flexion, extension is an up-down motion. Abduction, adduction is a side-to-side motion. So we would do the opening, knock, knock, knock. Hi, Ms. Jones. My name is Patty. I'm your CNA today. I'm here to do some exercises. Is that okay? Close curtain, wash hands. And then we're going to move the arm up like this, like they're asking a question 3 times, and out to the side like this, like they're making a snow angel 3 times. Move slow, move smooth, all the way to the start position, monitor for pain. That's the whole skill. It is, they give you 4 minutes. It is literally a 2-minute skill. Super quick and easy. So if I can get somebody to go over and lay in that bed for me, this bed over here, I will show you what this skill looks like. Go ahead and lay down for me. And I'm going to simulate hand washing just for the sake of time. Remember, it says her left shoulder, so it's going to be this one. You got to know your patient's right and left because they are different from yours. Hi, Ms. Jones. My name is Patty. I'm your CNA today. How are you? Great. I need to do some exercises on your left shoulder. Is that okay? Let me close your curtain. I'm going to go wash my hands, and I'll be right back. Come on. There we go. And remember, simulating means say. So I'm washing my hands now. I have clean hands. All right, Ms. Jones, I'm going to do all the work. All you have to do is let me know if there's any pain or discomfort as we do this, okay? First thing I'm going to do is bring your arm up above your head like you're asking a question, and then all the way back down to the bed. So we support from below. We support at the joints. So I want to support at the wrist and the elbow. And I'm going to go all the way up and all the way back down. Feel okay? I'm going to go up again, all the way up and all the way back down. Feel all right? One more. All the way up and all the way back down. Feel okay? Now I'm going to bring your arm out to the side and back like you're making a snow angel. You shouldn't feel any pain, but if you do, let me know. Again, support at the joints. We're going to go all the way out and all the way back. 1, out, and back. Feel okay? And out and back. Thank you. Is there anything else I can get for you while I'm here? Are you comfortable? You've got your call light there. Your environment is clean. Bed's in low position. She's safe. She's in the middle of the bed. Did I offer you a magazine?
Nope, Yeah.
Would you like a magazine before I go?
Thank you.
Are you comfortable?
Yes.
Good. All right. I'm going to wash my hands. Tell the evaluator my skill is done. Thank you. That's the last skill. You are now officially done with all skills. Wasn't bad, was it? Okay. No. I'm going to have to cancel this. I'm sorry. I will, hopefully by Wednesday, I'll have an idea. She is getting discharged. I just got the notice. So I've got to go up there and get her. By Wednesday, I should know when our makeup day is going to be. And I'll also send an email out as well with makeup information. All right. So Friday, you're going to return this book, yellow book. Not Friday, Wednesday. It has been a long day. Wednesday, you're going to return this book for me. You're going to keep the white one, the spiral one. That's yours. You can keep it. But the yellow one, please return. And I would say personally that the class that we're going to have Wednesday is probably the most important class of all. And I know you guys kind of think, well, yeah, but I had to learn the skills and, but I think class 8 is more important because yes, you've learned all this, but it wasn't hard. But class 8 is going to teach you what to do with it, how to find a job, how to interview successfully, how to answer that question. Tell me a little bit about yourself. How to just all of that kind of stuff, right? So it's Wednesday actually takes me about 2 to 2.5 hours to go through everything I've got to go through. We have to, once we get our certification, we have to know how to keep it. So how do you get continuing education? How do you renew your license? What does it take? Do I have to take the test again? All of those questions are going to be answered for you on Wednesday. So Wednesday really is a very important class. You don't want to miss it. It's kind of the next step, what to do with all of this stuff we just learned. And remember, we will take a class photo on Wednesday. All right. So let me give you your review sheet. No extra slides. Let me give you your review sheets. Anybody have any questions for me? Okay.
I was watching this morning and
Oh, good.
Yeah.
Very good. Yeah, that's one of the reasons that I live stream. It makes it more convenient for people that for some reason can't get here. At least you're not missing the entire lecture. You can at least listen in. You're welcome. And these review sheets, if you keep up with them as we go, it really does make a great review packet when you're getting ready to test and you're sitting in your car waiting for your turn. You just go through these review sheets real quick and read all of it, and it will help. And remember, you guys at home have access to this. You go to flcnatraining.com, FL for Florida, cnatraining.com. All of these review sheets are there. You just print them out. So if you're accessing us at home, go get those review sheets. They're there for you. All right. That is it for me. You've got not as much practice time as I wanted. You do have a half-hour practice time. You are welcome to stay and practice. If you can't stay, my blessings. We won't have class today for CPR. Just remember, I'm leaving. But I will see you on Wednesday for graduation, and I have a graduation folder for you as well. So those of you that aren't going to be able to attend Wednesday's class, you'll need to bring your yellow book back, give it to Jake, and sometime in the next week, please, because I've got to get ready for the next class. So bring your yellow book back, give it to Jake, and he will give you your graduation folder for those of you who are attending our classroom program but not physically here. All right, I will see you guys on Wednesday. Have a great day for you at home. Until next time, happy caregiving. Bye. Oh, Bryce, good question before I get off. Do we need to use military time when documenting for the test? Yes, you should. But if not, just make sure you write AM or PM. And Tanya or Andrea has exam on Wednesday. So nervous, great vibes out to you. I didn't want to sign off without giving you some good vibes. Okay, so great vibes out to you. You're going to do great.
Does it matter